Good morning. Welcome to day 2 of the Interoperative Neurophysiologic Monitoring Pathway for the California chapter of Neurodiagnostics. We'd like to thank you all for supporting the organization. Each of the presenters today are going to be introducing themselves. At the end of today's program, you'll have received 5.5 CEU credits approved by Asset. You don't really have to do anything to follow up to get those. My name is Christine Hanna, and I work for National Neuromonitoring Services as an Education Coordinator and Territory Manager in California. I'm really excited to be part of this organization who is providing you all with the opportunity to better your skills in the field of IOM. I'd like to thank all of the presenters for their time and effort in organizing presentations for us all. Hope you enjoy the program.
Hello, everyone. My name is Jeff Balzer. I'm an associate professor of neurological surgery at the Department of Neurosurgery at the University of Pittsburgh Medical Center. I'm also director of clinical operations for the Center for Clinical Neurophysiology. I've been at UPMC now for nearly 29 years and have a fairly large experience with doing intraoperative monitoring across many, many disciplines. What I wanted to talk to you about today was the advanced principles of motor evoked potentials. More importantly, where are we in 2020? So I think there's been an incredible evolution of motor evoked potentials over the last 20 years with regards to us adopting them, us doing them the wrong way, then doing them the right way, then a slow evolution of optimization of motor evoked potentials. And that's really what I wanted to talk to you about today was where are we now in 2020? I think to understand motor evoked potentials, I think to understand anything we do in clinical neurophysiology, as of those of you who know me, anatomy is really, really important to understand. And, you know, we often talk about SSEPs assay the back of the cord and motor evoked potentials assay the front of the cord. And it's while those are easy layman's terms to understand for people, it's actually quite complex when it comes to the descending motor anatomy. So there are different divisions of the corticospinal tract. There's a large lateral corticospinal tract, and that's the cross tract, and that's typically the tract that we're assaying when we do motor evoked potentials, or the one that is most injured during these types of procedures. If you look at the cartoon here, what you'll see is, ironically, that lateral corticospinal tract is not that remote to the dorsal columns that we record, excuse me, from the dorsal columns that we assay when we record somatosensory evoked potentials. So it's not like this front and back thing where these pathways are very disparate. And that's why I've gone on the record as saying, and I've said it before, and I still abide by this, this is why it's rare to see a complete abolishment of one of these modalities without a abolishment or at least a significant change in the other modality. There's also a smaller anterior corticospinal tract, which is an uncrossed pathway. It's really minute compared to the large lateral corticospinal tract. Between 80 and 90% of the fibers in the corticospinal tract decussate at the caudal medullary levels and enter the posterior part of the lateral funiculus, where they form this lateral corticospinal tract. So it's important to understand the fact that these pathways cross over at the level of the medulla from the contralateral hemisphere. So let's look at the anatomy a little bit more closely. So the lateral corticospinal tract descends the entire length of the spinal cord, and as it descends, it gives off fibers to the spinal gray at all levels and progressively diminishes at the more caudal levels. Obviously, once you transition at the conus from the spinal cord to the cauda equina, this doesn't occur. In the lower lumbar and sacral segments, which are caudal to the spinal cerebellar tract, fibers of the lateral corticospinal tract reach the dorsolateral surface of the spinal cord. So they're just sitting on the surface at that point. The anterior corticospinal tract, on the other hand, is formed from smaller portions of the pyramidal fibers, descends uncrossed into the spinal cord, and occupies an oval area adjacent to the anterior median fissure. So this is the true anterior pathway. Most of the fibers from this tract cross at upper cervical levels in the anterior white commissure and terminate in lamina 7. I'm gonna get back to the fact that there are different motor pathways that are descending, and how they cross and don't cross when we talk about some of the alarm criteria. So we'll get back to that. But I think it's insightful in terms of developing alarm criteria based on the anatomy. And I think one of the alarms that has been proposed, albeit not a whole lot of data for it, really supports this issue that not all descending spinal tracts, corticospinal tracts, are the same. The anterior lateral corticospinal tract fibers are uncrossed, very fine caliber, and descend more ventrally in the lateral funiculus. So what's the pathophysiology of the corticospinal tract? So I think it's important that once you understand the anatomy, you always have to understand, okay, so what happens if you disrupt these pathways? So the descending pathways are most concerned with voluntary, discrete, skilled movement. So anytime you have a lesion that destroys any portion of this tract at any level, it can result in variable degrees of paresis, i.e. paralysis, or plegia. Lesions are usually associated with a loss of muscle tone, succeeded by gradually increased muscle tone in anti-gravity muscles, hyperactive reflexes, loss of superficial abdominal and cremasteric reflexes, and the appearance of an extensor or toe response. So in other words, you can make predictions concerning the the integrity or intactness, if you will, of these pathways based on the examination of the patient. So for just from a nomenclature perspective, paralysis of both arm and leg on one side is termed hemiplegia. Paraplegia denotes paralysis of both legs, while quadriplegia refers to paralysis of all four extremities. So as it relates to motor evoked potentials, which is what this lecture is about, and I put this in here because I think it's a very valuable paper. And with regards to what are our expectations about the acquisition of motor evoked potentials in patients who are not quote unquote neurologically intact. This paper was published a couple years ago out of UCSF, where they looked at a correlation between recordable MEPs and motor function during spinal surgery. Now, these were a subset of specific patients, and the surgery was resection for thoracic spinal cord tumors. So this may not be applicable across all spinal pathologies, but it's the only paper I know of that gave us any insight about this. So basically what the summary of this paper was is that the ability to record myogenic MEPs is closely associated with the patient's motor function, and we would expect that. They are difficult to obtain if motor function is 3 out of 5 motor strength in the lower extremities. They're almost impossible to record if motor function is worse than 3 out of 5. So why is this a valuable paper? Well, this is valuable because everybody's done a case where a patient comes in the room and they're myelopathic, or they have a thoracic spinal cord tumor, or they have cervical myelopathy, et cetera, and you say to the surgeon, I'm really having a difficult time getting lower extremity MEPs in this patient. And they look at you and say, I don't understand. They walk just fine. Or I don't understand. They're 3 out of 5, or they're 2 out of 5, or they're anti-gravity. Well, this gives us some correlational evidence of the fact that this is when we should expect these. And I'll also talk about this when we talk about anesthesia. This is also very, very important with regards to the anesthetic approach that's used during MEP recording. Because if the patient's neurological status is already putting you behind the 8 ball with regards to recording viable MEPs, a non-optimal anesthetic regimen can only put you further behind that 8 ball, and that's important to keep in mind. So let's march through motor evoked potentials, and we'll do this, I think, in a very orderly fashion, and then we'll end up with where we are today. So why did we start doing motor evoked potentials? Well, we noted that there were case reports that existed with regards to SSEP insensitivity. And while these case reports are rare, there have been postoperative motor deficits in the absence of SSEP changes reported in the literature. I can tell you as I sit here that most, if not all, of the cases where we've seen MEP changes in the absence of a quote unquote significant SSEP change were patients did not wake up plegic. Patients woke up with a graded motor change. In other words, they were never 0 or 1 out of 5 or even 2 out of 5. They were 3 out of 5 or better. So I think that using SSEPs in conjunction with MEPs as a multimodality approach is absolutely the way to go here. A lack of a change in an SSEP in the case where they're sensory intact but motor decreased should not be thought of as a false negative, right? Because we're not monitoring motor function when we do SSEPs. Nonetheless, that insensitivity led to the development of intraoperative assay of descending the more lateral and ventral pathways involved in a generation of voluntary motor activity. I'm not going to go through the history of the development of motor evoked potentials because everybody remembers neurogenic potentials. Um, and how they fell to the wayside because we realized that we probably weren't even assaying the descending motor tracks. We were probably assaying the anadromic sensory tracks. But what I'd like to start with is what we did before we did motors. So before we had motors, we had something called a Stagnera wake-up test. And basically what we would do is tell the patient to wake up and move your feet. So this was a very rudimentary test to see whether or not the patient was quote unquote neurologically intact after procedures such as scoliosis and derotation of the spine. Everyone knows that through our experience with monitoring the spinal cord in these cases and motor evoked potentials, that just because somebody can wiggle their toes doesn't mean they're neurologically intact in their lower extremities. So because of the potential shortcomings of doing a wake up test, and not to mention the fact that anesthesia has to wake the patient up, which freaks them out, we developed electrophysiological techniques to assay these descending motor pathways. So this is the only history I'm going to go to. So the original development had several different stimulation sites. We first started stimulating the spinal cord, and this was done either directly with subdural or epidural electrodes. And there was also indirect stimulation of the spinal cord using a transosseous technique that was described early on by Jeff Owen as the neurogenic potential. And then it was transcranial stimulation. It was done, which involved either electrical or magnetic stimulation. As I said, stimulating the spinal cord directly was shown vis-a-vis collision testing to not be a true assay of the descending motor pathways, but rather the major contribution of that recorded response was from the anadromic activity in the ascending sensory pathways. So let's talk about transcranial stimulation techniques. I'm not going to talk about transcranial magnetic stimulation after this one slide. It can be used to activate corticospinal tracts and produce pure MEP responses. The recordings may be directly from the spinal cord, from the peripheral nerves, or from the upper and lower extremities. The practical fact of the matter is that we don't have a FDA-approved method by which to generate good MEPs in the operating room using a magnet, and that's typically because the magnet itself doesn't generate the high frequency trains of stimulation that need to be delivered to generate these responses. So transcranial magnetic stimulation at this point in time is used almost exclusively as a therapeutic tool in diseases such as depression. So let's talk about transcranial electrical stimulation. Again, a little bit of history. It's existed for a long, long time, 5, 6 decades even. And there's been a variety. If you go back through the history of this, you can find a variety of stimulation and recording techniques that have been used to produce motor evoked potentials. Ironically, early stimulation studies that were done by Levy consisted of a 3 by 5 centimeter plate placed over the motor cortex on the scalp, which was the anode, and then a second electrode placed against the hard palate in the mouth. And while that sounds fairly barbaric and sounds like something you might see in a movie, it makes intuitive sense from a developmental standpoint that this is exactly what people might do, because what it does is it places the motor fibers and the motor cortex between the anode and the cathode. And to best deliver and most efficiently deliver these stimulus, that's what you would want to have happen. So let's talk about optimization of motor evoked potentials. So in these early studies, they basically reported there was a lack of reliability, and what they were so insightful even 25 years ago that they predicted that repetitive trains of longer pulses may be better for producing MEPs. Um, Remember, there was still no TIVA. The anesthetic was clearly not optimized either, but clearly we understood that we needed high frequency trains with longer pulses. So the response size and the consistency of the responses that we're recording back then were related to a number of different variables. And this is really where the evolution of motor evoked potential recording began. So first, the stimulation electrode configuration, where we put them on the head, the type of electrode we used, the type of stimulation we used, the application of multi-pulse stimuli, and the choice of the anesthetic agent. So we're going to talk about each of these individually, and we're also going to look at the literature that guides us and helps support some of the decisions we make with regards to the choices we're making now when we do motor evoked potential. So let's start with stimulation electrodes. So different types of scalp electrodes have been successfully used. These include subdermal needle electrodes, EEG cup electrodes, corkscrew electrodes, and adhesive gel pads. So I don't know what most people out there are using these days. We use traditional 13 millimeter needle electrodes, and we get very nice responses. Corkscrew electrodes were originally used in the earlier studies, and quite frankly, they were used out of necessity because in the old digitimer stimulators, that if one of your electrodes were happened to be pulled out of the head, the current was still delivered and it was always looking for a return. In other words, if you lost an electrode, you could deliver a very a high density charge that was looking for a place to return to, like maybe the Bovie pad, et cetera, et cetera. So corkscrew electrodes are allegedly more secure than our needle electrodes, but I think a needle electrode with a staple in it, it does the job as well. But the question becomes, is one of these electrodes better at generating motor evoked potentials? Not is it safer, et cetera, because obviously you could argue that putting holes in people's scalps doesn't help, and it could be deleterious. Those corkscrew electrodes are pretty thick, so that's another thing to consider as well. Um, anyway, so has anybody ever looked at that? Well, in fact, they have. So this was a paper published, look at this, 2004, right? Almost 20 years ago now. The influence of electrode impedance on threshold voltage for transcranial electrical stimulation in motor evoked potential monitoring. I don't know if any of you know Louis Journet. He's a brilliant biomedical engineer, physician out of Groningen, and he's published a whole host of papers, not just looking at the utility of motor evoked potential monitoring, but really getting into the weeds concerning which way to do it best, and really doing some very elegant work with regards to defining the parameters and the electrodes we use. And what they concluded in this study was there was a tight correlation between the electrical stimulation voltage threshold and the electrode impedance, and that can be markedly reduced by using electrodes with large contact surfaces, resulting in limit values of these parameters. It may also improve the reliability of the motor evoked potential monitoring. So guess which electrodes actually work best? Cup electrodes, right? Big surface area, big charge density. You get a better motor evoked potential at a lower stimulus threshold. What about scalp montage? Let me go back to that. That being said, I think that you are able to, in most cases, and certainly in our experience, get very good motor evoked potentials with needle electrodes, and there's probably even more surface area of the electrode when you use a corkscrew electrode because of the diameter of the needle itself. What about the montages we use? Well, again, if you go back to the literature and you look at the history, people used to put electrodes everywhere. They used to use circumferential montages where they put electrodes all around the crown of the head, if you will, and reference all those to CZ. And we'll get to that in a second, because isn't that reminiscent of what we call quadrupolar stimulation now? But we'll talk about that when we get to that. What we also found was that anodal stimulation is most effective at generating a motor evoked potential, and the particular montages result in larger populations of motor neurons being synchronously depolarized, i.e., moreover, result is current delivered deeper in the brain. And as I said, various stimulation montages have been utilized for successful generation of transcoronal motor evoked potentials. I think the figure, the bottom cartoon there that I mocked up is the one that most people use, and that's a C1, C2, C3, C4 montage to generate motor evoked potentials. What I will tell you at our institution is that anytime we're doing motor evoked potentials, we put extra electrodes on the head in every case. and so that we're redundant about what we're able to stimulate on the fly without approaching the field ever again. So we always put C1, C2, C3, C4, and then oftentimes we'll put a pair of electrodes anterior and posterior to C3 and C4, so that if we're not getting good or reliable motor evoked potentials, we can always just simply switch to those montages and see if those optimize our recordings. So what do we know about this? Has there ever been anything published with regards to optimization of motor evoked potential monitoring based on stimulus parameters and montages? Well, certainly you can go back to Andrea's paper that was published in 2007, and Carl and Vedran were both on this paper as well. And what they concluded is that in patients with normal neurological status, i.e. normal motor status, using total intravenous anesthesia, pulse duration of 0.5 and an ISI of 4 milliseconds provide the lowest motor thresholds. Pragmatically, they showed that C1, C2, C2C montage provided monitorable responses of both APB and tibialis anterior muscles, but what they also showed is the use of C3 or C4 references CZ can also be recommended if you're looking for differential, more focal hemispheric stimulation. So clearly, this has been studied, and this data exists out there. So we're not guessing anymore about what's best. This paper was also published in 2018, only a couple years ago, by Louis Journet out of the Netherlands. And basically what they showed is biphasic stimulation at C3, C4 is advised when constant voltage stimulation is used to monitor the spinal cord during orthopedic spine surgery. Corkscrew and small needle electrodes are highly sensitive to electrode impedances. So again, they talk about not only the montage, but what types of electrodes should be used. And this paper was published in Scoliosis, I believe in 2010. And basically their findings suggested that cross-scalp stimulation resulted in MEPs obtained ipsilaterally and contralaterally, which may be contributed to by summation of ipsilateral and simultaneously transcallosal or deep white matter conducted stimulation. So again, very nice studies that have been done that have given us guidance as to what montages we should be using. Lastly, I'll mention this paper, which was published in 2006. And you say, well, why do we use anodal versus cathodal stimulation? And basically what they showed in this paper using a modeling study was electrode polarity and electrode position over the precentral gyrus and central sulcus have a large and distinct influence on the response of cortical elements. So really important to understand all these principles. But I think we're at a point where we have a relatively good consensus about what types of electrodes to use, what types of montages to use, and how we go about doing these. So this is a paper I referred to early on when I talked about the 3 out of 5 versus 4 out of 5. Excuse me, though, this is a different paper. This is from the Spine Journal from 2017, where they talk about success rate of motor evoked potentials using constant voltage compared to constant current stimulation, which is really interesting because guess what? We've used both, depending on the machine you have, depending on how you run them, et cetera, et cetera. Basically, what they showed is that the success rates of MEP recording from deltoid, APB, quad, tibialis anterior, and AH muscles were significantly higher using constant voltage stimulation than those using constant current stimulation. The overall success rates in constant voltage and constant current were 86 and 68 respectively. Really important piece of information to understand. Okay, let's talk about the parameters themselves, how we deliver the stimulation. So we've decided where we're going to put the electrodes. We've decided whether we're going to use anode or cathodal stimulation. We've decided whether we use constant voltage or constant current. And we've decided what type of electrodes we want to use. So what about the parameters we use? So an important parameter for eliciting reliable MEPs is related to stimulus repetition and interstimulus interval. And why is this important? Well, remember, we're trying to overcome the effects of general anesthesia, oftentimes in the form of TIVA, but nonetheless general anesthesia in these patients. So synchronous activation and depolarization of a large pool of neurons and or axons in the cortex that ultimately result in a polysynaptic response in the form of a MEP, a compound muscle action potential in the periphery, is very, very difficult to do under situations where the patient has general anesthesia on board. What we've found is short duration multi-pulse trains used to elicit activity in order to overcome this depressant activity. Maximal response augmentation has been reported to occur with an interstimulus interval between 2 and 5 milliseconds for a train of stimuli up to 5 pulses. So again, can we go to the literature and find any guidance with regards to what's best? And that definitely exists. You know, typically people would say 5 pulses with an ISI of 2 milliseconds is best. But we can also now go to the literature and find information concerning what are called priming pulses. And that is either a single pulse or a train delivered before the application of the train designed to generate the motor evoked potential. So double train stimulation was described by Dr. Genet all the way back in 2007. And basically what he showed was that if you deliver a train followed by another train, what it does is the preconditioning stimulation reduces the resting membrane potential of the neurons such that a subsequent train delivered at the right interstimulus interval is then more likely to synchronously depolarize that population of neurons and as a consequence generate a motor evoked potential. What they also showed in this paper in 2004, so now we're going even further back in time, was that the timing between the trains was really, really important. And that if you use these priming trains, you could use less stimulation to elicit a motor evoked potential, which is important, right? Because it's an advantage for two separate reasons. One, it might allow you to garner MEPs in a patient who's neurologically compromised, who otherwise you could not get an MEP from if you're using conventional, just single high frequency trains. And two, and this is really important, using priming pulses or priming trains and the ability to reduce the stimulus intensity needed to generate that MEP can also reduce the amount of patient movement in this patient population. So it also might be the case that using priming trains and we do this all the time now, is that you're able to use stimulus intensities of say 200 volts or 225 volts, which results in very, very little patient movement, which means what? Which means you can collect the MEPs at a higher frequency. There's also a paper that's been published that looks at peripheral tetanic priming stimulation. So stimulating the tibial nerve as if you were going to generate an SSEP at a specific time point and interstimulus interval between the stimulation of the peripheral nerve and the delivery of the train also can cause a facilitation of the MEP response as well. So we don't often think about the fact that there's this interplay between the ascending sensory and the descending motor activity, but that clearly exists. It clearly exists and should not be overlooked as well. And as I mentioned earlier, we're oftentimes or almost always doing multimodality monitoring in these cases as well. I would caution everyone to read these papers to look at what these optimal ISIs are, and you can see that there's actually a chart in the paper by Journet from 2004 that you can see here that talks about what the optimal interstimulus intervals are. So what's happening here? As I mentioned, the first pulse or first set of pulses, the first train reduces the resting membrane potential of the motor neurons. And that way the second train is more efficient in creating a depolarization secondary to more positive resting membrane potential. And facilitation appears to be extremely dependent not only on the number of pulses, but also on the interpriming interval. And that's really important. I'll tell you, I did my dissertation on looking at input-output curves of hippocampal and cortical neurons and looking at random train stimulation. And I can tell you as I sit here that while there are certain interstimulus intervals that facilitate responses or the second response to a pair of stimulation, there are also interstimulus intervals that depress the response in the pair of stimuli. So you have to be very, very careful. If you don't get that sweet spot or hit that sweet spot, you actually might be depressing your ability to get the MEPs, not enhancing it. Let me talk for a second about quadrupolar stimulation. And what I want to go on the record as saying first is that as of March 30th, 2020, which is when I'm recording this lecture today, there is not one paper that it can be searchably found on PubMed that talks about quadrupolar technique or stimulation with regards to generating MEPs. So while people have talked about quadrupolar stimulation now for 3 or 4 years, um, I cannot find a publication that describes it or describes its advantages or explicitly describes its advantages based on data that's been collected. So basically, what's the technique? Conventional transcranial electrical stimulation utilizes one anode and one cathode. We all know that. What quadrupolar stimulation utilizes are two linked anodes and two linked cathodes. So essentially, I think quadrupolar is a bit of a misnomer, but the term really is stuck. So this is basically just linked anodes and linked cathodes. And what do you do when you link two anodes and link two cathodes and deliver stimulation? You get a higher density of intensity of stimulation delivered to the scalp and consequently down to the brain. So what were some of the early findings with quadrupolar stimulation? Somewhat higher upper extremity and much higher lower extremity MEP amplitudes with quadrupolar stimulation, and that makes intuitive sense. Often we're able to record reliable MEP responses with less than 100 volts of stimulation intensity. And I think, quite frankly, that is the most attractive thing about doing this if you're going to try it. And why? I'll go back to the whole idea that I spoke about when I talked about priming pulses, is that once you get to these types of stimulation intensities, your motor evoked potential monitoring can be more continuous than what is typically done these days, where they're done either at the request of the surgeon or whenever we think something untoward may have happened. One of the things we also know is the orientation of the coupling may influence the MEP acquisition. There was a talk given at our meeting in Pittsburgh a couple of years ago where they not only looked at coupling anodes and cathodes, but they looked at different orientations of the couplings and showed that that could influence the MEP acquisition. Patient movement may be reduced, although, like I said, it really does depend on the stimulation intensity. Tongue laceration actually may be a bigger concern secondary to stimulation spread over a larger cortical area. But again, this really depends on the stimulation intensity you're using to elicit your motor evoked potential stimulation. Okay, so we now have electrode type, electrode montage. We have anodal versus cathodal stimulation. We have where we put the electrodes on the head, and we have the optimization of the types of stimulus trains that can be used to deliver MEPs. And I think that I don't mean to suggest that there's any consensus ever in medicine, but I think we're pretty much all on the same page conventionally with regards to all those things. Let's talk about anesthetic considerations, because unfortunately, even we occasionally run into problems with anesthetic considerations, and I think this is really a bigger problem than people recognize because of the dogma that's been put forth with regards to TIVA anesthetic, and I'll get to that in a second. So anesthetic optimization. So what we know is reliable and reproducible responses have been shown to be recorded with nitrous opioid techniques as well as propofol opioid anesthetic techniques. We also know that you can record MEPs with some potent inhalational agents on board. The important thing to remember when you enter a case and the anesthesiologist is adamant about using any gas is that it is a fact. It is a fact that the utilization of gases in these cases decreases the sensitivity and specificity of the motor evoked potential recording. No ifs, ands, or buts about it. If you want to optimize the recording in these cases, you have to use TIVA. What do I mean by that from a standpoint of everyday doing cases? If you want to use a little bit of desflurane or a little bit of sevoflurane in a 14-year-old undergoing idiopathic scoliosis surgery who's otherwise neurologically intact, you're probably going to be able to record MEPs. But if you see a change in the MEPs with gas on board, at any time during that case, even during a derotation, the first thing or one of the things that absolutely has to be on your differential diagnosis for what caused that change is the gas. And if it is a gas, that means it's a false positive. And if it's a false positive, that means your sensitivity and specificity has been decreased by the utilization of that gas. That's number one. Number two, I think using the same approach in every case regardless of whether it's a pediatric case, an adult case, a neurologically intact patient, or a neurologically non-intact patient, is absolutely the way to go in these cases. Because what I ran into early on when we first started using TIVA, where I'd have an anesthesiologist say to me, "Oh, well, we used gas yesterday and they got really, really good MEPs. Why can't I use it today?" And you got to go through the whole diatribe about, well, this is an 80-year-old with myelopathy and already has 3 out of 5 strength. And so the likelihood of me getting lower extremity MEPs without any gas on board is going to be lower, let alone when you put gas on board. So it's really important. No muscle relaxation should be used except that was necessary for intubation. And even then it should be short acting so that you can get your MEP baselines ideally before they cut skin after intubation. The ideal anesthetic approach is total intravenous anesthesia using no gas whatsoever. So what we also know is like I said, you can get these responses, but even low dose concentrations of these gaseous inhalational agents can wipe out your MEPs. So what can we point to in the literature to help our anesthesia colleagues understand this? So this was a paper that was published back in 2014 that looked at the differential rates of false positive findings in MEPs when using inhalational agents versus total intravenous anesthesia. So this is the holy grail of us making our point with regards to TIVA. And what they showed in this paper was that use of inhalational anesthesia during adult spine surgery is associated with significantly higher rates of false positive changes compared with TIVA. So this isn't saying that you can't get MEPs when you use gas. It's saying that when you use gas, the false positive rate is higher. And that's a problem because that's why we're there. We don't want false positive rates. And ironically, they also showed that the relationship appeared to be independent of the preoperative motor status of the patient. What they further went on to look at was an analysis of the anesthetic agents, the diagnosis and symptoms, and you really need to know that these impact these findings. So it's really important to use TIVA in these cases. So the question then becomes, is TIVA? And the answer is that it's not all the same. And what I'll show you in the next slide is that what we now know is that there's a significant effect of propofol accumulation during these procedures and a anesthetic fade that might occur. So this was a paper that was published just last year that looked at the impact of total propofol dose during spinal surgery. So not the infusion rate, how much was given totally over time. And what they showed that an intraoperative total propofol dose of greater than 1,550 milligrams, larger variation in body temperature and greater blood loss are independently associated with false positive alerts during spinal surgery. So not only do we know conjecturally and through some animal studies that we have anesthetic fade of motor evoked potentials over time, we now have a study that quantifies the fact that you just can't give as much propofol as you want during these procedures, or you're going to see these problems. And here's the issue, right? Think about the issue here. The issue is when are a lot of these high risk surgical maneuvers done in these procedures? They're done later on in the cases, while we're taking intramedullary spinal cord tumor, while we're derotating the spine. So you really have to be cognizant of that. This is just an example from that paper that shows these fade alerts that were based on the propofol and nothing that was done with regards to the patient. I pulled this slide from a talk that I was at in Boston, and this is the algorithm that Cincinnati Children's Hospital uses for their propofol, and I think it's brilliant. And we're in the midst of adopting this at our place as well, and it's really important with regards to the propofol. So they use a bolus up front. They use a certain infusion rate for 40 minutes. Then after that, for 2 hours, they reduce the infusion rate. Then after those 2 hours, they reduce it again. So what they're doing here is they are cognizant of the fact that if these cases are going 5, 6, 7, 8 hours, what they don't want to have is this giant accumulation and total propofol administration being given, because what can ultimately do is it can wipe out and cause anesthetic fade. The other thing it does is it allows for the quickest wake-up test if you need to do one, because your propofol hasn't been running at a high rate and at a total amount for the entirety of the case. You're actually reducing the propofol as the case goes on. So this was from one of the neuroanesthesiologists at Cincinnati Children's. So how can you gauge the effects of anesthetic on the motor evoked potentials? So I'll tell you one of the things that we do, because TIVA can also be deleterious based on infusion rates and the amounts. It's really important to have some index of our ability to record motor evoked potentials. So in every case that we do MEPs, we record 2 channels of raw EEG to gauge the level of burst suppression. We don't do it for depth of anesthesia. We do it simply to say, if our MEPs begin to change, or if our MEPs go away, has our EEG gone from being active to being burst suppressed? And if it's gone from being active to being burst suppressed, we then look to anesthesia to start adjusting infusion rates so that the EEG comes back to a a more reasonable frequency, and we see whether or not then the MEPs also change in accordance with the level of anesthetic that's being delivered. So if the EEG is flat or near flat and we see changes in MEPs, we consult with anesthesia first. One of the things that we've found is how remarkable it is that a small increase in propofol infusion can have profound effects on the EEG. So just going from an infusion rate of 150 to 175 can take active EEG and make it flat. And you know, sometimes you scratch your head about the motors and, oh my God, the lower extremity motors are gone and the upper extremities are there. Um, but the EEG is flat. So all these things weigh into our ability to allow to index what's causing the change in the motor evoked potentials. What are some of the other things that weigh into motor evoked potential reliability? Certainly patient characteristics and anesthetic techniques do that. This was a paper that was published out of Mount Sinai by actually Don Weiss was on my master's committee way back when at the University of Pittsburgh. The conclusions of this paper were diabetes, hypertension, and anesthetic technique were the most important patient risk factors associated with the failure to obtain lower extremity MEP signals. These results will improve anesthesiologists' ability to tailor anesthetic regimen to patient comorbidity. So again, we always talk about, oh, they have diabetes, it's gonna be hard to get. There's data out there to support all of our claims. And we should know this data, and we should have this data available to us when we talk with our anesthetic colleagues. Now, I think so. I'm not going to go through the list again because it's becoming like the 12 days of Christmas. But so we're now at a point where we think we have or are able to optimize our anesthetic technique with regards to MEPs. What about alarm criteria? Well, this may be the most controversial thing that still exists with regards to motor evoked potential monitoring, only because we walk a fine line between optimizing alarm criteria and optimizing sensitivity and specificity of the motor evoked potentials we're recording from. Because remember, the alarm criteria that we use will ultimately dictate whether or not the collection of motor evoked potentials is preventative versus predictive. In other words, if they go completely away, we have data that shows that that's highly diagnostically accurate with regards to the fact that the patient will wake up with some decrease of motor function after the cases. So alarm criteria. We know MEPs are sensitive to the detection of neurological deficits and certainly predictive of outcomes. There have been a variety of alarm criteria that have been described, most using changes in waveform amplitude as the dependent measures. Others have reported, and this was certainly earlier on, that huge variabilities in amplitude exist and that decreases up to 80% in baseline amplitude did not correlate with any postoperative deficits. And this is where the all or none criteria came from. So what are the different criteria that have been implemented and utilized to alarm surgeons during recording of motor evoked potentials? Changes in amplitude, changes in threshold, and changes in morphology. And we'll talk about each of these and the pros and cons. So again, all of you who know me, I'm big about understanding the literature, reading the literature, and seeing what's out there. So there was a series of papers published in the Journal of Clinical Neurophysiology back in 2017 that looked at each one of these different criteria. And this was a paper published by David McDonald, which was an overview on the criteria for MEP monitoring. And what you can see is basically what he said is tailoring warning criteria to different monitoring situations based on the anatomy, the surgical goals, and published evidence seems advisable. And that sounds really good, and it makes really good sense. But unfortunately, that is not always the case, and it's not always attainable. And what do I mean by that? Why do SSEPs work as well as they do? They work as well as they do because most, if not everyone, loosely follows a 50% decrease in amplitude, which in all of our experiences has proven to be highly diagnostically sensitive and specific to a reversible change that's occurring, right? That number, those kinds of decreases in amplitude just don't exist for motor evoked potentials. In fact, if you want to use alarm amplitudes to do that, you can see what we're measuring is a polyphasic waveform. We don't even know where to measure these damn things. And we know there's so much, even if they're there's a tremendous amount of trial to trial variability oftentimes in the complexity of the waveform, the amplitude of the waveform. And while several different percent changes have been proposed, um, proposals with regards to the components of the complex EMG waveform that should be measured are really not abundant in the literature. So what do I mean by that? Everybody will say, oh yeah, use a 60% decrease in amplitude or use an 80% decrease in amplitude, but yet they don't even show you how they're measuring the amplitudes. Are they using the first most positive against the second most negative component of the waveform? They just don't tell you. In fact, in most cases, what they describe as an amplitude change turns out to be an all or none presence of an EMG response. So this figure is taken from a paper that extols the virtues of using a decrease in amplitude as the alarm criteria. And what I will tell you is that every time they alarm, in this case, the responses are gone, not necessarily down in amplitude. So this was a paper published by, again, Louis Journet, that looked at the percentage of amplitude decrease warning criteria for transcranial MEP recording. And basically what they showed was that a change in amplitude is the best thing to use, and using multiple muscle groups in terms of incorporating that into your alarm criteria is best. More explicitly, if you wait till the responses are gone, you're really not helping the surgeon to help the patient. This was a paper published by Karl Kothbauer, talked about the interpretation of these. And ironically, what he says, to date, the best correlation of muscle MEP data to clinical deficits lies in assessment of disappearance of a previously present MEP, regardless of threshold or amplitudes. Remember, this was published in 2017. So again, like I said, there's very little consensus in medicine. I think with regards to MEPs, we're furthest from a consensus when it comes to alarm criteria. What about threshold alarms? Significant change involves an amplitude change in CMAP induced using just above threshold intensity. So what is proposed in these cases is you get your MEPs and you turn down your stimulation intensity until you're just above threshold. If your MEPs begin to go away or do go away, you turn up the stimulation intensity. And if you're able to reestablish your MEP based on increasing the stimulus intensity, then that should be the alarm that something is going on, particularly if the intensity has to be increased by a certain amount, 25-volt increments. Um, so, so, so I think that this is a reasonable approach to doing these. But if you're doing recordings from multiple muscle groups, what it requires is for you to develop thresholds in every one of those muscle groups and then follow the change in those thresholds at each one of those muscle groups. In other words, you're going to be a super threshold in some groups to be just at threshold in others, and vice versa. So I think the practical application of these types of alarms is difficult to do with conventional IOM machines. Nonetheless, Blair Clancy published this paper in the same journal in 2017. Um, um, Basically, ironically, this got published with this last statement in his summary section that says, it is much better for patient welfare to be using some form of NEP monitoring than to use none at all while you wait for consensus about alarm criteria to emerge. In other words, basically what he said is use MEPs even though we don't have a consensus. But what he would argue is that if you use an all or none criteria, you're really not helping the patient. Uh, Morphology alarms were proposed several years, over 10 years ago. I've only seen one paper that has really extolled the virtues and advantages of using morphology alarms, and it was published out of UCSF, and it was published in a series of one particular type of surgery, and that was not spine surgery. It was brain surgery. Specifically, it was aneurysm surgery. And basically what it says is that CMAP response to transcranial electrical stimulation is typically recorded as a multiphasic waveform, and we know that, and that's a fact. The proposed alarm criteria in this paper is based on the change in waveform morphology. Specifically, what they said is that a change from a complex multiphasic waveform to a bi or triphasic waveform may portend poorer outcomes. Once again, if you look at this data, while this is certainly a change from poly to bi or triphasic, it's clearly also a significant change, right? And it's just a snapshot of one or two. I think that to repeat your measures to make sure that the change that you're seeing, whether it be in amplitude, whether it be in threshold, or whether it be in morphology, it's consistent over time is really important. I'll tell you, it's never really been picked up on, but I also like this type of alarm based on the fact that damage to descending spinal cord pathways, and in the brainstem and in the brain that contribute to the MEP are not exclusive to one pathway. So anatomically, this type of alarm makes sense to me in that what you might be able to do is predict that there's some damage being done, but it's not a reversible damage or not a damage that will necessarily result in the patient having non-recoverable motor deficits. So it does have some anatomical substrate to it. We published this paper through one of our Indian colleagues back in 2017, alarm criteria for motor evoked potentials. And basically what we showed through a meta-analysis was that no statistically significant difference was between using reductions in amplitude of 50% and 80% as an alarm criteria were found in terms of sensitivity and specificity. And the total loss was found to have a statistically significant increase in specificity. In other words, 50 to 80, whether you use 50 or whether you use 80, you're going to have an increase in the false positive rate and a decrease in the sensitivity and specificity. And what we showed through a literature search was that obviously an all or none criteria is going to tell the story about what's happened, but we're here to prevent these injuries, not to predict them. And what we showed was TCMEP monitoring is a highly specific and sensitive diagnostic tool for detection of neurological deficits. What about the application of MEP? Just to keep with the same theme, I would advocate using a decrease in amplitude of MEPs, but I would also advocate that alarm criteria and the initiation of an alarm to the surgeon is only done in conjunction with an oversight neurophysiologist. In other words, while an 80% decrease in some instances may mean nothing, it may mean something in other instances, and that's what McDonald alluded to. So in other words, what I would argue is that the alarm for motor evoked potentials, unlike that for somatosensory evoked potentials, has to ultimately be based on an interpretation of the data, not just the recognition of change. So what about application of MEPs? MEPs generated and recorded during using a variety of methods, and it's used during many different procedures which place the spinal cord or vascular supply at risk. We also now use transcranial MEPs and direct cortical stimulation during a variety of cranial procedures, both brainstem, supratentorial tumor resection, and aneurysm clipping. In fact, people would now argue that if you're not doing MEPs, when you do aneurysm clippings on vessels that put perforating vessels at risk, then you have no way to know whether or not you've affected subcortical structures like the internal capsule. What types of spine procedures? Certainly cervical and thoracic spine procedures for decompression and stabilization. Procedures posing potential spinal cord ischemia during repair of thoracoabdominal aortic aneurysms. And I talked about that in my other lecture. as part of this course. It's really an invaluable tool there. Resection of intramedullary and intradural spinal cord masses, correction of stabilization, and there's also recent data to support the utilization during lumbosacral procedures, a paper that was published out of Jefferson that Dr. Walent is, I believe, the first author on, looked at over 4,000 spine cases and looked at the advantages of adding motor evoked potentials in lumbosacral procedures, and did not only show that it's diagnostically accurate, but it also improves outcomes in those procedures. So I would encourage everyone to look at that paper as well. Last thing I want to get to is the exclusion criteria for MEPs, and I think this has really changed over time. And I'll tell you what we do. Um, and in some instances, I can't give a good reason for why we do it, but I'll tell you what we do. So certainly evidence suggests that transcranial electrical stimulation poses no significant risk to normal patients, i.e. you don't burn them, the tissue doesn't heat, there's no hearing loss, there's no headaches, no permanent changes in EEG, there's no kindling seizures in these patients, and we have no evidence that it changes memory or compromises cognition. The most cited complication attributable to transcranial stimulation is a self-inflicted tongue bite associated with strong facial contraction. So clearly, whether you're doing transcranial stimulation, direct cortical stimulation, you should have a bite block in place so the patient doesn't bite their tongue or bite their lips. Seizures with multi-pulse stimulation may be of concern, particularly in patients with a seizure disorder, although the incidence of is negligible in spine procedures. So if we have a patient, let me talk about brain surgery first. If we have a patient who comes to the operating room, and the reason they're in the operating room is they have a GBM, and the way they presented was that they had a seizure, we don't even think twice. We do motor evoked potentials. A sentinel seizure or several seizures attributable to that brain tumor is not epilepsy. So we would never consider not doing MEPs in those cases. It turns out that we now don't even consider a seizure disorder a reason not to do these in spine surgery. So this was a paper that was published 2 or 3 years ago, looked at the incidence of intraoperative seizures during motor evoked potentials in a very large cohort of patients. So this was over 4,000 patients that were studied. And basically, the authors report the incidence of intraoperative seizures in patients who underwent MEP monitoring during a wide spectrum of surgery, spine surgery, peripheral nerve surgery, interventional radiology, craniotomies, et cetera, is very, very low. The low incidence of seizures induced by electrical brain stimulation, particularly short train stimulation, demonstrated MEP monitoring is a safe technique that should be avoided due to the risk of inducing seizures. So this was all comers. They didn't exclude anybody with epilepsy. And if you looked at the incidence of seizures, it was negligible in spine surgery. It was 0.2%, 3 out of 1,664 procedures. The highest risk of inducing a seizure is when you put a grid down or you use a ball tip probe and you do direct cortical stimulation. But we do it all the time. We're prepared for it. You have your ice cold saline, et cetera, et cetera. So the last thing I'm going to talk about in terms of exclusion criteria is, if you look at the old literature, we say you can't do transcranial stimulation with implanted devices. So surgeons will say to me, "Hey, this patient has a pacemaker," and my answer would be, "Yeah, well, that's been thought to be a contraindication for transcranial electrical stimulation." And they'll say to me, "Why?" And I'm like, "Yeah, I don't know why. I'm not sure why. It's just that's what everybody says." So what we've adopted is a policy that unless the implantable, either the IPG or the device itself, is cranial. And what do I mean by cranial? We do not do MEPs in patients with cochlear implants, and we don't do it from a safety perspective. We don't do it because we don't want to damage the device itself with current spread. And again, I don't know if that's going to occur, but that's just what we've adopted. We've done MEPs in patients with pelvic floor stimulators and spinal column stimulators, et cetera, and it works just fine. And anecdotally, we've had no problems at all. And quite frankly, in these types of cases, the surgeon's approach to this is that the risk that they might be taking with regards to doing the motors are far outweigh the risk of not doing the motors in the cases to begin with. So let me summarize very quickly here at the end. MEP recording is a vital technique to assess motor function during a variety of surgical procedures, including craniotomy. Montages, electrode types, and anodal versus cathode stimulation is now established, and we have reached somewhat of a consensus. Stimulation methods for generating MEPs are still evolving to provide the most reliable responses while reducing the intensity and patient movement. But again, we're really getting close to having very, very good techniques. What does exist is a clear debate over the optimal alarm criteria for MEP recordings. What is clear is that while highly specific, an all or none criteria is not optimal for preventing injury. And the point there is, and again, this is a double-edged sword. If you're going to use amplitude, right? The lower you go on the change in amplitude as your alarm criteria, the higher the probability of having a false positive. So if you want to use 50%, go ahead and use 50%, but you're going to get bit at some point where that 50% decrease is nothing more than trial to trial variability in that patient population, contributed to by diabetes, hypertension, all the things we talked about in this talk. So I think that using a prudent amplitude change and really interpreting that change, not just using a number, um, in couched in what was going on during the procedure, what the patient's pathology is to begin with, is really the way to do these things. So they're more complicated to do because you really do have to have, unlike SSEPs where you look at the surgeon and say they're 50% down, I would never look at a surgeon and say they're 80% down. I would first run through an entire algorithm of all the things we've talked about before I did that. As exclusion criteria evolve, it is now clear that seizure risk during spine surgery, even in patients with epilepsy, should not exclude the utilization of MEPs in these procedures. The last thing I do want to touch on before I end here, and something I didn't include in the talk, but I think is salient when it comes to MEP recording, and certainly weighs into our sensitivity and specificity and our ability to help the surgeon, is the frequency with which we record these potentials. I think if you're doing an MEP at the beginning of the procedure and you're doing an MEP at the end of the procedure, you're not doing the patient any good. I think if you're waiting for the surgeon to tell you when to do motor evoked potential, then you should have a discussion with them about the fact that the neurophysiology team is best served to understand when an MEP might be done during these procedures, and more importantly, the surgeon oftentimes is focused on what they're doing and forgets completely about the fact that they haven't run an MEP because they're used to doing SGPs, which are transparently run during the entire procedure. The bottom line is optimal MEP recording involves the recording of MEPs at the most frequent pace that we possibly can during these procedures. And while this isn't oftentimes possible, which is understood, we should strive to do these as often as we possibly can with the cooperation of anesthesia and the surgical team. Well, thanks very much. And again, I want to thank Rebecca and her team for putting together what proves to be a very nice meeting. I'm disappointed that I couldn't make it to California and interact with all of you and answer any of your questions. But if you have any questions about what I presented or want me to give you access to some of these journal articles, feel free to email me at balzerjr@upmc.edu. I hope everybody stays safe and healthy during this very unusual time, and thanks again.
Due to COVID-19, our newscast is unable to come into the studio for this week's update. We have authorized a stand-in who is immune to this strain of the coronavirus. Good evening, everyone. My name is Regina Martinez, and this is Next Gen Neuro's Weekend Update. A little bit about Next Gen Neuro. We are a certified service-disabled, veteran-owned, and women-owned company that delivers on-demand, high-quality, affordable, continuous EEG monitoring and other neurodiagnostic services across the United States that are tailored to your specific needs. Also, we've been self-quarantining forever because we monitor remotely. In real time, our registered EEG technologists are available to continuously monitor your patients on demand with 30 minutes notice or less, like Papa John's, but less greasy. We have about as many services as the Tiger King has lawsuits against him. Here's a list of our services. CEEG real-time continuous monitoring, and that's with the patient-to-tech ratio of 4 patients to 1 tech. CEEG real-time intermittent monitoring, and that could be clinical with the patient-to-tech ratio of 6 patients to 1 tech, or intermittent technical, which is 12 patients to 1 tech. Retrospective review of the CEEG, reading physician services, consultation and management, statin routine EEG, neurodiagnostic aids, hookup training, with the option to do the hookup training fully remote, so that way you won't even need to shake our hands in person. We also have supply packets, ICU CEEG ground up program build, and finally, neurodiagnostic program management. You can read more about our services on our website at www.teamngn.com. Our Go Live Services implementation process is so easy and painless, unlike watching Jessica and Mark's relationship on Love is Blind. After just a few calls to discuss logistics, we will go live in no time, seamlessly integrating with your team. If you're sick of scrolling through social media and only seeing Tiger King and COVID-19, you can check us out on our social media channels. We're on Twitter, Instagram, Facebook, and LinkedIn at these handles. Thanks for tuning in to the Next Gen Neuro Weekend Update. Stay healthy, happy, safe, and wash those hands.
Hi everyone, I'd like to thank the California Neurodiagnostic Society for inviting me to speak virtually, and I'm very happy to be here. Today I'm going to talk about intraoperative neuromonitoring for intramedullary spinal cord tumor surgery. Just to set the stage, got an image here of lesions involving the spinal cord, and as you can see here on the far left, you've got intramedullary, so entirely inside the spinal cord. And then you've got intradural extramedullary, so outside of the spinal cord, but inside of the dura. And then you've got extradural, so outside of the dura. And today we're mostly going to focus on intramedullary. In general, for the most part, when you see intramedullary spinal cord tumors, they are most frequently either an astrocytoma or an ependymoma. There are other intramedullary lesions, but these are the ones that I think you tend to find most frequently. And of course, working inside of the spinal cord, you've got some very important structures that we can monitor. You've got the dorsal columns here, so the fasciculus gracilis, which is your represented by your lower extremity SSEPs, fasciculus cuneatus represented by your upper extremity SSEPs. And if we think of this whole side here being the right side of the spinal cord, so this would be your right leg and right arm, and this one over here would be your left leg and left arm, so these are your dorsal columns. And then you've got your laterocortical spinal tract, which is shown here on the other side of the spinal cord, and the SLTC is for sacrolumbar, thoracic, and cervical, so that's sort of how it's organized. And then you've got your anterior horn here, your gray matter, representing where the lower motor neurons are. So this is your corticospinal tract coming down from the brain, and then those branch off to synapse with your lower motor neurons, which ultimately go out to the muscle. So in terms of this, in terms of the stages of surgery, once the spinal cord is exposed, there's an opening of the dura, then there's a myelotomy, hopefully, not always, but usually there's a goal of going midline between the dorsal columns of left and right side of the body to access the tumor. There's the resection of the tumor, and then there is putting the dura back together, so suturing the dura and then closing up. The goals from our perspective are to monitor and map sensory and motor function to reduce morbidity and guide resection, and to give the surgeon feedback so that they can maintain confidence and optimize outcomes. Obviously, the surgeon wants to get as much tumor out as possible, so we're trying to balance gross total resection with neurologic outcome, and that's one of the challenges. Other challenges that we can think of from a neuromonitoring perspective are as you think about the fact that you're cutting into the spinal cord and extracting a tumor. There's a lot at risk here. MEPs may or may not be available at baseline. They can exhibit far more variability than they would usually in a typical spinal decompression fusion. They're frequently lost. Motors are frequently lost during resection. SSEPs are often not available at baseline and are frequently lost during the myelotomy portion, so cutting into the spinal cord. EMG has very limited utility during these procedures. And other tests, for example, reflex tests like H-reflex, is of unclear prognostic value. So today, I'm not going to focus on motors and SSEPs. Essentially, I'm not going to focus on monitoring. I think they're both important, but I think if you're doing these procedures, you should be fairly well skilled, or if you're starting to learn these procedures, you should be fairly well skilled in motors and SSEPs and how to run them, how to respond to them, how to troubleshoot them, so on and so forth. So what I want to focus on today are the two critical, I think, other mapping or monitoring modalities, which are dorsal column mapping to ultimately identify the physiologic midline of the spinal cord to help reduce morbidity associated with dorsal column dysfunction, and then also D-wave monitoring. So dorsal column mapping. The idea here is that, so here's a cartoon cross-section of the spinal cord. I just showed you this, but you've got the lower extremity represented on one side, so the fasciculus gracilis representing, in this case, we'll call it the right lower extremity. And then over here, just next to it, you've got the fasciculus gracilis representing the left lower extremity. And what we're trying to do with dorsal column mapping is find the physiologically silent midline here, which may or may not be obvious to the surgeon, in an effort to find the best place to cut into the spinal cord and reduce as much as possible the possibility or extent of dorsal column dysfunction. Now, nothing's guaranteed, but there is some evidence to suggest that post-operative dysfunction of the dorsal column is observed in general in about 45 to 50% of patients undergoing intramedullary spinal cord tumor resections. But one study showed that that number dropped from 45 to 50% to 9% in patients who had dorsal column mapping. So, so there is the possibility of certainly reducing dorsal column dysfunction. So why would we need to do this? Certainly, as you can see here on the left-hand side, so this is a normal, in A, you've got kind of a normal spinal cord. Obviously, it's a cartoon. But in B and C, you've got intramedullary tumors there. And in B, you can see there's cord rotation and enlargement, which is secondary to, it's supposed to be a syrinx there. And then in C, there's a distortion of the midline, which is secondary to an intramedullary tumor. And the landmarks that a surgeon may use may or may not be available. So resection can become complicated by cord edema, by arachnoid fibrosis, capillary neovascularization. So you can get cord rotation, you can get asymmetrical enlargement, and just in general an obscuration of the midline. So what we can do is we can stimulate the spinal cord, and we can find the what is the left side and the right side of the dorsal columns, and then after having identified them, we can do our best to find the midline where we don't see any dorsal column activity or the least amount. Now there's 4 different ways to do this, at least 4 different ways. I'm just going to tell you my preferred method. I think it's fast. I think it's simple. It's clear. I've never had issues with it. As long as the patient has SSEPs, you should be able to get this. And essentially what you're going to do is you're going to stimulate the spinal cord and you're going to record from the scalp. And before I go into this, I just wanted you to think about this fundamentally for a second. If I were to stimulate the left PTN, doing a typical PTN SSEP, I would record from the scalp and I would get an SSEP. So I get call it a P37. And if I were to stimulate the right PTN, I'd do the same. The only thing that we're doing here is we're stimulating the pathway. So in some ways, it's no different. We're just stimulating the spinal cord, the area of the spinal cord that represents ultimately the left leg somatosensory function, the right leg somatosensory function. We're going to record from the scalp. So we're going to rely on a phase reversal here, and this image is taken from original papers that showed what we all know as paradoxical lateralization. But the point here, I want you to look at the left side of A. That's the one I want to focus on, where you see that red circle on the left by C3. And what this demonstrates here is that if you stimulate the left PTN, you will get a P37 peak or trough, whatever you want to call it, trough actually, right here, which is shown there, over C3. Now, that's if we stimulate the left PTN. The same would be true if we stimulate the left side of the spinal cord. Although it wouldn't be 37 milliseconds, it would be shorter, but we'd still get that same formation. Now, I want you to ignore this circle on the right here, but the point that I want to make here is that, okay, so if we stimulate the left side of the spinal cord, we're going to get this trough that's going to happen at some milliseconds after the stimulation. If we move over to the right side of the spinal cord with this exact same recording at C3, this is simply going to flip upside down. So it's going to invert. You'll see a reversal of phase. Okay, so I want to show you that in real time here. Here's an image here. I'm stimulating the left side of the spinal cord. Okay, and this image here on the left, you'll see there's a stimulation here between 4 and 5, and there's a stimulation here between 2 and 3. And each of those contacts are on different sides of the spinal cord. So 2 and 3 here is the left side of the spinal cord. And what you see here is your typical lower extremity SSEP waveform. So that's the morphology we should expect. Now you'll notice that it's coming in at 10 milliseconds and not 37 to 40 milliseconds, and that's because we're stimulating the cervical spine. Now what they do is they move over to the other side of the spinal cord, stimulating the right side. Still, one recording here, CP3 to CP4. So your primary recording site is CP3, and what happens is this inverts upside down. So what we know is that the physiological midline between the dorsal columns exists between these electrode contacts, and likely where this line has been drawn here, and that's where the surgeon's going to want to cut into the spinal cord to access the tumor. Now that image, I'll go back here a second, that image showed you what is essentially an electrode that's no longer available. It may even have been handmade for this purposes. It's quite a few years ago. But you can do this just as well with a side-by-side bipolar, which you see in this image. And the way that you do this, and you can see they're stimulating, marching across the spinal cord. So they're on the right side, then they're on the midline, then they're on the left side. And the images that you see here are clearly, here is a morphology that you would expect with left lower extremity stimulation. The primary recording site here is CP3. There's the inversion here. And then in between, there's a relatively flat response. It's not always going to be perfectly flat, but you want to look for the flattest response after you've found the reversal of phase. Now, there's a lot of people out there that want to add a whole bunch of recordings. They want to record from pop fossa. They want to record from Erb's point. They record from the upper extremities and cervical spine. No, 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 no. You're looking for fasciculus gracilis on the left, fasciculus gracilis on the right. You're looking for the midline. You don't need all of those other recordings. It's just cognitive noise. So here's what not to do. Don't set up all of these extra recording sites. They're just cognitive noise as far as I'm concerned. They're going to add more confusion than anything else. This is the system that I use, by the way, everybody has different systems that they use, but this is how I don't set it up, but I'll show you how I do set it up. There's going to be some images here with some slides here with a lot of information on them. This is a recording, so it's great. You can pause it and go through it if you want. I'm not going to go through everything on every slide. And this is probably a good time to tell you that I'm actually going to have more slides in my handouts than I do here, because I want you to be able to dive a little bit deeper and have some more information than I have time for here. But the one thing that I want to point out is that you're going to use one recording montage, CP3 to CP4. And you should expect normal polarity response when you stimulate the left side of the spinal cord, and you should see that invert when you stimulate the right side of the spinal cord, always working closest to midline. Okay. The probe you're going to use, I've seen people use a monopolar probe. I wouldn't recommend it. You have to stay very low, and you have to be careful of the idea of spread. It can work. Look, if you're a neurophysiologist, advanced technologist, or whatever, you carry with you every day monopolar and bipolar probes. There's just no exceptions to that. You need to be ready for everything. And in this case, you're working with an intramedullary spinal cord tumor. You have to be ready for just about anything. So you need to have a bipolar probe with you. You can use a concentric bipolar probe, or you can use a side-by-side. I haven't found a difference. My preference is to have a bipolar side-by-side probe with the tips facing rostral and caudal, up and down, not side to side. And if you can tell the difference, it's best to have the cathode facing toward the head. Keep the intensity low. About 2 milliamps generally works well. You don't need to go any higher than that. Everything else is there. And you're basically doing an SSEP. So it's just an average response. You're stimulating just like you would an SSEP. It's just the intensity is lower. And you're averaging the response. You shouldn't need many averages. As I say here, 30 to 200. I haven't seen really the need to do more than 30 to 50. It's always good to know what to expect in terms of latency. I think this is from a NAIR paper, what they found at various levels, what to expect in terms of, okay, you stimulate at C2, what kind of latency should you expect? Where should you look for that peak and trough in the SSEP? As you'll see later, when you do monitoring and mapping of the spinal cord, knowing what latency to expect is critical if you want to get accurate information. So this is a pretty straightforward technique. There's no need to spend more time on it. I'm going to move on to D-wave monitoring, but I do want to mention, in case I forget later, I'm going to show you some latencies for the D-wave and one study that did some interesting things. And one of the things that they did was they stimulated the spinal cord, and they looked for SSEPs, or responses that were sensory from the scalp. And they also have a lot of latencies in there. So you should really get a general idea before you start this in any given surgery, what latency you should expect. All right, D-wave monitoring. So hopefully everyone knows what a D-wave is, but just kind of dive in for those of you who are new, and maybe provide a little bit more for anybody else who's not new. What this image demonstrates, left side, it's cartoon image, but anodal stimulation over motor cortex results in an electrical volley that descends through the corticospinal tract. And what you see here demonstrated in this figure is, at least on the right, is that if you have multiple corticospinal tract volleys that are appropriate in frequency and duration and intensity, they can depolarize the lower motor neuron. And that comes through spatial and temporal summation, ultimately leading to muscle depolarization. So the D wave is the electrical volley, which you can see right here, that's recorded from the dorsum of the spinal cord with an electrode, that results from direct activation of the pyramidal cell axons in the brain after you've delivered a pulse here. So think about this. If you do a motor evoked potential, you generally have like 5 to 7 pulses, right? And we call that multi-pulse stimulation, or pulse train stimulation. 5 to 7 pulses. Each of those pulses produces a D wave. And collectively, when those D waves make their way down to the lower motor neuron in rapid succession, they activate the lower motor neuron. So now we're over here on B. And it becomes more and more excited, hopefully to the point of reaching threshold where an action potential is generated in that lower motor neuron. And if a bunch of them become activated at the same time and make their way out to the same muscle, then you'll get a muscle motor evoked potential. But each of those 5 to 7 pulses will be an individual D wave that you can record off the spinal cord. Now, when we do this test, we don't want 5 to 7 pulses because we're not trying to produce a muscle response. We're just trying to produce an individual D wave. So instead of doing 5 to 7 pulses, we're just going to do 1 pulse. Now I'll come back to that. So single pulse stimulation produces a D wave. I'm not going to go into I waves, but the idea here simply is that, as you can see, this is a recording, an epidural recording from C4. And I'll show you what the electrode looks like in a minute if you haven't seen it before. But at an intensity of 0 volts, obviously you get no response. 75 is not quite enough to get any response. You just get some stim artifact there. But as you increase the intensity, you'll start to see a D wave that comes in. And you'll see it grows in an intensity, grows in amplitude until it can't get any larger. And then you'll see it actually increase in latency just a little bit. Decrease latency just a little bit. And that is because you're driving the current deeper into the brain, activating these axons lower in the brain, so you're just making it a little bit faster. So when you do this test, you want to increase the intensity to the point that the response doesn't get any bigger, and it doesn't, and it's as short as it can possibly be. And this just demonstrates the multi-pulse stimulation. So each of these are D wave recordings from the spinal cord, and below is a recording from the thenar muscle in the hand. And you see that you need multiple pulses, at least 3, before you can actually get a muscle response. So you should be able to do this test, the D wave test, without causing patient movement. You might get a little bit of movement in the face with high intensity because you're activating the facial nerve peripherally, but you should not, with 1 pulse, get any movement in a sedated patient, in a patient who's under general anesthesia. You need multi-pulses to overcome the effects of the anesthesia. All right, so here's the electrode. If you search D-wave electrode, and I get this question all the time, if you search D-wave electrode on Google, you will find nothing, because that's not what it's called. It's called an epidural spinal electrode. And what this simply demonstrates here's the electrode. I'll show you a real one in a second, but there's a couple of contacts here. The contact is about 1.3 millimeters long, and then there's 15 millimeters between them. Go to this next one here to show you what these look like and a little bit closer. So here's what the electrode actually looks like. This one has 2 contacts. This one has 3. They come in both 2 and 3 contacts. They also come with a tooling needle, which is for placement of this electrode in in a situation where you don't actually, you're not actually doing spine surgery, not opening up the spine. They can place it through this electrode. I've not seen that done here in the US, so usually what we do is just throw this in the sharps container. Now, if I forget to mention this later, I'll mention it now. You'll notice that there's 15 millimeters between these 2 electrodes, and there's also 15 millimeters between these electrodes. The purpose of having these 3 electrodes is not so that you can have a whole bunch of recordings. A lot of people like to do contact 1 to 2, 2 to 3, 1 to 3. That's 3 recordings. You don't need that. The reason that there's 3 contacts here is because the optimal recording distance to get the best response is 30 millimeters. So best case scenario, you get this electrode, you just record 1 to 3. This other one is here in case you need to troubleshoot. You need to use a different recording. Maybe for some reason this one here just can't get contact and you have to use a different one. That's what that's for. But you shouldn't have a whole bunch of recordings, because I'll use this term a lot. I always use this term, cognitive noise. The more information you have, the more likely it is that you'll make a mistake. You don't want to be overloaded. You need what you need to make the right decision. And what you need here is 1 to 3. So that's the montage. If you're working low enough on the spinal cord, meaning you're not up at like C1, C2, you should be able to place an electrode above the lesion, an electrode below the lesion. And the idea here is that you're recording, forget about I waves, we're not going to talk about them today. There's absolutely no use during these procedures, and they're often not even present in anesthetized patients. But the idea here is that you're going to do a rostral recording, a caudal recording, and you'll do a comparison between them. They should be about the same, although the caudal will be a little bit smaller because there's less axons there, and a little bit later because the signal takes a little longer to get from here to here as it moves its way down the spinal cord. But this is really a control. It's not critical, but it is helpful, particularly for troubleshooting. So you can't always have a control, but when you can, it's beneficial. So above and below, midline. Here's what a D-wave might look like. So once you get a good one, you set a baseline, and this is just an example here. This is a high cervical case, and we're not able to place an electrode above because we're too high on the spinal cord. So we place one below, and the latency here is 3.2 milliseconds, and we're just comparing each test against baseline, and you definitely don't want it to get smaller. I'm not really going to go into interpretation of these today. I'm more going to go into the troubleshooting aspect of it. There's plenty of literature on interpretation, and I've included it in my handouts later, but I'm going to skip over it because one of the hardest things to do in D-Wave recordings is simply to get them. There's a lot of troubleshooting that goes involved in it. There's a lot of people that give up on D-Wave recordings when they could have gotten something. They just might not know how to go about it. So that's what I'm going to focus on today. But the idea here anyway is that you want to you don't want your D-Wave to go below 50%. That's really where you want to recommend aborting surgery. I'll leave it at that. Everything else is in the handouts. Here is the methodology. I'm not going to go into all of this. You can pause it and study it if you want. But the important thing here is the number of pulses that you have is n equals 1. Now here's the setup in the system that I use. R stands for rostral, C stands for caudal. So R is rostral electrode contact 1, rostral electrode contact 2, so on and so forth. So this is if you have three contact electrode. And what I've done over here is I've shown you the most important contacts. So these are the ones you're actually going to be recording from. So rostral contact 3 to 1 and caudal contact 1 to 3. Why are they opposite? Because one's facing up and one's facing down. So you do that in order to keep the polarity the same. And then here's how it's set up in the channels. And this is set up as an evoked potential. So it's set up as an average response. And here I have an average count of 5. I've used up to 30, and usually you don't really need any more than that. I mean, you shouldn't really have to average much. There's not a whole lot of variability between them. Trial to trial variability is about 30%, so it's pretty good, pretty stable response. But you do want to average to get a nice response. So somewhere between 5 and 30 works. And here's your critical train length, n equals 1. So amplitude and latency, what this shows here is your stimming C4, C3, so that's your motor stimulation with 35 milliamps, generally stimulate in volts, so just think of this as 350 volts, for example. And you'll get a D wave here, rostral, but nothing caudal. You increase the intensity, now you've got a nice rostral and a caudal D wave. And you'll notice that this is recording at cervical 6.7 and thoracic 7.8. So not only is this smaller, but it's delayed in latency as well, which is expected. Anesthesia really doesn't have much effect on D waves. And unless you get up to several Mach, you might start to see some changes. But remember that anesthetics, for the most part, affect synapses. And when it comes to motors, particularly inhalational anesthetics, their function is not in the brain in prohibiting motors. It's in the spinal cord. And the D wave is an asynaptic response. So we're recording something that has not passed through a synapse. So you're really not going to see any effects on D waves. Neuromuscular blockade can be beneficial to D waves in that it will get rid of the muscle artifact and clean it up. But the challenge there is that you're giving up the ability to monitor motors and EMG. So you have to make a decision as to what's best. I've never seen the need to give neuromuscular blockade to monitor a D wave. If you troubleshoot properly, you shouldn't have any issues. This just shows going from 0.6 Mach of ISO to 0. There's really no change in either amplitude or latency. This, as I said, it's asynaptic, but it is an axonal response, and as axons cool, the latency can slow down. So you can see that just with cooling, this is obviously a very old slide, but you see a little delay in latency there. Some warm irrigation should clear that up, no problem. Okay, this is super important. So in about 20% of patients who have intramedullary spinal cord tumors, whether it's due to the tumor pathology or post-radiation myelopathy, and it's really important that you ask the patient if they've received any radiation, because in about 20% of patients, the D wave is not present at the beginning of surgery, and it's not going to become present, even if the motors are recorded. And the reason is because you have desynchronization of the D wave. So if you think about it, this is reminiscent of patients who they come in for a standard spinal decompression fusion, whether it's posterior cervical or what have you. And despite the fact that they have normal proprioception and tactile sensation in their lower extremities, you just can't get SSEPs from the lower extremities. I'm sure we've all seen that before. Why is that? Well, it's because of their spinal pathology that all of the axons that represent the lower extremity, they transmit the action potentials at slightly different conduction velocities, very slightly different. And when they get up to the brain and they get averaged, they come in at slightly different latencies, and they ultimately average out to a flat response. And that's why you don't get an SSEP. The same is true with a D wave in patients, as I said, who have tumor pathology or some sort of radiation myelopathy that's created a desynchronization of these action potentials. You probably just won't get a D wave, you get a very small one. So what this shows here is here's a nice compact D wave, and here's one that is protracted. So it's not compact, but it's much smaller and it's spread out. And that's what you'll see sometimes in these patients, a very small or non-existent D wave. So it can result in altered morphology, a wide base, a low amplitude, or even an absent D wave, and you just need to be prepared for that in about 20% of patients. Here is a debate about whether or not to focus on this much, because these are just numbers that I collected over time, and I stopped collecting these numbers quite a few years ago. But these are just latencies that I recorded at different levels of the spinal cord in adults. And the reason that I stopped recording them was because the reason I was doing it was to get for myself a sense of what to expect in terms of latency. But luckily, in 2016, a really good paper came out by Costa and Delitis, where they looked at D wave for a different purpose, but they at least tracked D wave latencies, and that's what I want to focus in on here. So just real quick, if you look at level here where my cursor is, this is a thoracic tumor, cervicothoracic, thoracolumbar. So these are the different locations of the spine where the tumor is. This is whether or not muscle motors were present. So plus is present, ABS is absent. And then here's your D-wave recordings. So cranial and caudal to this tumor location. Now this study I think is really cool because they did something called an anti-D wave where they're stimulating the spinal cord and they're recording the motor component response over primary motor cortex. And that's differentiated by latency from what would be a sensory response because they also have these spinal cord EPs. So these are evoked potentials recorded from the scalp after stimulation of the spinal cord. So these latencies here, if we go back to the dorsal column mapping, are latencies that you can fall back on to expect, okay, when should I expect this peak or trough to come in, stimulating this level of the spinal cord. All right, but let's focus on D waves right now. So super important to get an idea of when you can expect this to come in based on various levels, and I'm going to show you why right now. So here's an example of a D wave recording. Take a second and look at it and tell me where's the D wave. So here's cranial, here's caudal. So we're trying to get a baseline here. And so we've got something here, and I can tell you this is a high cervical case, and this particular electrode, this is a cervicothoracic case, so it's a low cervical case. So the cranial electrode is kind of high cervical, caudal electrode is cervicothoracic or even high thoracic. All right, and we've got a 2 millisecond time base here. So where would you place your markers? Well, if you said here, you would be wrong, and you would be monitoring what in this case is an artifact. The real response is here. So look back. Everything's inverted. Here's the response here. 4.1 milliseconds, which makes sense at the cervical spine. And what we have here is a desynchronized D wave, so we can't monitor this. But it is appropriately, if you look at the latency being a high thoracic recording at 5.3 milliseconds, that makes sense. So this is where the D wave is. We can't get one caudal, we can't really monitor it. So if we had marked this by accident, we would have been giving the surgeon the wrong information throughout the procedure. So know your latencies. All right, D waves in children. I just thought I'd throw this in for those of you who do PEDS cases. So here's a study from Andrea Zelny, D waves attempted intramedullary spinal cord tumor resection, 19 children. I'll let you pause and read through this because I think I put everything in here that you need, but I just want you to have this information so that you know that they can be done, but there are challenges. Okay, some pearls. So place the electrode midline above and below the lesion if possible. You may be limited by the level of surgery. I'm going to let you read through a lot of these, but for right now, and you can pause and read through them, but I want to focus on simply what's bolded right here. So the D-wave electrode is an epidural recording electrode, but you can place it subdurally. So if you have problems getting a recording, that's what you can do. So start epidurally, place it on the midline, and if you simply can't get it, if you're having a bunch of challenges, try placing it intradurally. And not only should you hopefully get a response at that point, but it will be an order of magnitude larger because you're not recording through the dura. So you'll get a much larger response, which is sometimes nice. I said before the trial-to-trial variability was 30%. I was wrong. Sorry. This is an accurate number. It's about 8 to 10%, so it's even better. That's why you don't need so many trials. Like I said, 5 to 30, the average should be pretty good. Make sure you have impedance matches, so do an impedance test. I got to tell you, probably the number one reason that I see people that are unable to get D waves is because they don't have impedance or they don't have matched impedance, so all they record is noise. So if you start your recording and all you're getting is noise, number one thing, check your impedances, try to match your impedance, work with the surgeon to get good contact. Because the number of axons that make their way down the spinal cord from the brain to synapse on the lower motor neuron, the number of axons is much higher in the cervical spine and a much lower number in the thoracic spine. The amplitude of the D wave is always going to be much higher in the cervical spine. And you'll see about half the amplitude in the thoracic spine, and then it reduces more caudally. As I said, the amplitude is improved with increased distance between the electrodes, but there's a sweet spot. So 3 centimeters is thought to be best, and that's the argument for the 3-contact electrode. Lots of people think about D waves in terms of intramedullary spinal cord tumors, but I found them to be useful in extramedullary tumors as well. So I recommend them in rare cases, but situations where either we're unable to get any motors at baseline, which should be extraordinarily rare unless the patient's paralyzed, or if you suspect there's a very high probability of losing muscle MEPs during the course of surgery. So severely myelopathic patient who doesn't have a whole lot of function. You have basically blips of motors at the beginning of surgery. You're pretty sure as soon as they pull off that lamina, you're going to lose your motors. D-wave's a good test because that can give you the information, give the surgeon the information that he or she needs to confidently continue with the surgery. So, but one thing that I want you to keep in mind is that the D-wave is a recording of the axons. It's recording from the axons as they conduct down the spinal cord. So if you were to have a localized stroke or ischemic event to the gray matter, so segmental gray matter stroke, you're not going to pick that up with the D-wave. That's where your motors come in. That's where not just doing motors in general, not just doing motors from the hands and feet, but doing motors from the various myotones will help to pick those things up as well. What to do by location. So high cervical, you probably won't be able to place a cephalic electrode, so distal only. Low cervical, you're unlikely to have an upper extremity specific deficit, so it's best to place the electrode further down to make sure that you're in the high thoracic spine to monitor long tract function. Be careful in the lower thoracic spine. You can place an epidural electrode over over the thecal sac. So basically recording a wave from the cauda equina, but it's not a D wave. So never place the electrode below the conus. There's a very high risk of false negative there. And I don't think anybody's ever really looked into that wave, but I've certainly recorded it on a number of occasions. And it can remain present despite the fact that there's a loss of function. So interesting to look into someday. There's really no benefit to getting proximal recordings if you can't have a distal recording, but you might want to consider other tests like a BCR, for example, in low thoracic recordings. Let's see, what else? If the D wave is absent, so D wave's absent at baseline, increase the stimulation intensity. Try to do a proximal / cranial recording, so cephalic recording. If you can get it above with no problem, but you can't get it below, then there's probably it's probably not going to be possible to get it. If your D wave is obscured by stimulation artifact, try matching the impedance, work with the surgeon to get good contact, place the electrode intradurally. Sometimes that will fix the impedance problem as well. When all else fails, consider other tests. So you can do H-reflex, you can do BCR, you can do, you should be doing dorsal column mapping anyway if possible. And there's also intraparenchymal stimulation, so you can do mapping of the corticospinal tract. I didn't talk about that today. Most surgeons that I've talked to over time don't find it beneficial. Some people use it, but I'm not really sure what benefit they get from it. There's only a couple of papers on it, but it's super easy to do. Anyway, when the D wave is absent at the beginning of surgery, patients can tolerate about a 50% decline in MEPs. Greater than a 50% decline should not be tolerated. Certainly a loss of motors with no D wave at all should be a pretty significant warning for the surgeon. Like I said, I didn't put much in here about interpretation of the D waves, but it's certainly going to be there in your handouts. I already mentioned a couple of these things, but if the D wave is ugly, if you're still trying to figure out how to make it better, how to improve your recording, you can try to do a couple of these things. You can, I generally start with a low cut, which here is called a high pass filter. I usually start at 1.5, but studies have reported that you can increase that up to about 50 hertz. So you can try to cut out some of that slow wave noise. And let's see, I think I already mentioned a couple of these things. So in summary, there's a variety of techniques that are available to monitor and map spinal cord function. Standard approach to monitoring should include muscle MEPs, D-wave, SSPs, and EMG, and I would also add dorsal column mapping to be a standard approach, at least being offered to the surgeon. It depends on whether or not they have the landmarks available to them to see where the midline is. D-wave, when done properly, represents the engram of the corticospinal tract, meaning that the amplitude of the D-wave is directly representative of the number of functional corticospinal tract axons. And as those axons become injured, the amplitude gets smaller. Literature suggests, and this is really a high-level overview, but please go in and look at the slides that go into detail about interpretation and recommendations to the surgeon. But literature suggests it's okay to proceed with complete loss of motors, so muscle MEPs, as long as the D-wave amplitude is greater than 50% of baseline. It has been, dorsal column mapping has been shown to significantly decrease deficits of dorsal column function. Corticospinal tract mapping, while I didn't review that, it is possible. It's of unknown utility, and we certainly need more data on estimating the distance to the corticospinal tract if that's the goal. So that's all I have to say here today about this. If you want more detail, please do look into the handouts that I sent. Don't have the ability to answer any questions right now, but I thank you very, very much for your attention, and I hope you are all healthy and safe and have a great day.
Hello, California Neurodiagnostic Society. Justin Silverstein here, and we're going to discuss eloquent cortex monitoring and mapping. So brain mapping. These are some of my favorite procedures. I do these every week, or I had been until New York stopped doing surgeries. But these are my most favorite types of craniotomies to monitor and be a part of. And the goal today is to walk you through some of the techniques and describe them, discuss them, show you how you can implement them in your own practice. If you're not currently doing them, it's not too difficult. You just have to really pay attention to details. Some disclosures here. I am not conflicted for this talk. So we are going to talk about cortical mapping and monitoring for these procedures. Typically, cortical mapping is performed in craniotomies where the eloquent cortex is at risk. So that's your motor cortex, your language cortex. You're going to do this in surgeries for tumors, seizures, aneurysms, different kind of cerebrovascular cases. Some will be more geared towards mapping. Some will contain both mapping and monitoring, and some will be focused more on monitoring. So for example, in tumors, you might do mapping and monitoring. You might just do mapping, you might just do monitoring. In an epilepsy surgery, you might just focus strictly on mapping and not do any monitoring. And then in aneurysms, at least what I typically do is we don't really do mapping, we focus on the monitoring. And the reasons for that, which is a little bit outside the scope of this lecture, but feel free to hit me up in my email, which I'll get at the end of the lecture. If you have any questions, feel free to contact me. Because again, this is more of an overview of mapping and monitoring versus the specifics. So first we're going to start out with sensory motor localization, also known as the phase reversal technique. So this is one of the most reliable ways to identify the central sulcus. The phase reversal technique is an SSCP that basically is recorded directly off of the scalp. So it's very, very simple in those terms. It's no different than you doing a median nerve SSCP. The only thing is that you are now replacing your C3 or C4 electrode, for example, with this strip electrode. So the peak latency of the negative peak should match what your peak latency is of your scalp SSCPs. So we still do traditional SSCPs typically when we're doing a phase reversal technique. We don't just strictly rely on the phase reversal only, especially in cases where you're not monitoring, where you're only mapping, because you want a pilot for that phase reversal. You want to know where the SSCP should fall, after you take into account the patient's history and their underlying comorbidities and so forth. So traditional SCP should be attempted for troubleshooting purposes, and the subdural electrode, which is now, like I said, going to replace your C3, CZ, C4 electrodes, they will be referenced to FZ or FPZ. So I'll go back to this picture. So this strip electrode is plugged into your acquisition box, your amplifier box, or whatever machine you're using. This is a recording electrode. Well, all of these contacts, 1 through 6, or if it's a grid, 1 through 8, 1 through 12, however, whatever you're using, these will all be referenced in your machine. So these will be your actives, and your reference will be a FZ or FPZ. And in a lot of cases, it can't be true FPZ or FZ. You have to lateralize it to keep it away from the surgical incision. Sometimes where they're pinning the head, so on and so forth. So I tend to lateralize my FZ or FPZ, my reference electrode, the best that I can. What's nice about the phase reversal technique is that if you're going to do direct cortical stimulation, which is a motor stimulation, the phase reversal technique reduces time spent on performing DCS. So if you strictly go for direct cortical stim without knowing where you are, you potentially have, false negatives. You might not get a response, and you might think you're on sensory, but it might be that you're having some kind of technical problem. So the phase reversal allows you to know where motor is, know where sensory is, and then you can then dial in your direct cortical motor stimulation. Now, typically we use the median nerve because the median nerve has a very simplified morphology, tends to have higher amplitudes than other nerves. It's not as at risk for a positional issue as an ulnar nerve is. So a median nerve is a strong nerve to use, and you get nice, robust responses. And what's nice about the phase reversal technique is that it does not trigger seizures like a direct cortical stimulation, because again, you're not using that electrode to stimulate with the phase reversal technique. You're using it to record. So you're not causing any electrical activity in the brain directly. So the thing about the phase reversal technique and the waveforms you actually get is you get a robust sensory response noted with a drop in amplitude occurring at the central sulcus, and then a reversal of the phase seen in the motor cortex. So the evoked potential seen in the sensory cortex following the median nerve stimulation is usually at a peak latency of about 20 milliseconds, right? So that's our N20, followed by a positive deflection. So if we have an N20 followed by a positive deflection of about 30 milliseconds, well, when the subdural electrode is placed over the motor cortex, you get this mirror image a few milliseconds later than the sensory response. So this allows for real-time assessment and intraoperative feedback to the surgeon. It's more specific than preoperative imaging because brain shift and anatomical displacement doesn't inhibit its reliability. Where a surgeon might think sensory and motor could be completely different due to a tumor. So that's why this technique doesn't lie when it's done correctly. So it allows for accurate detection of eloquent regions when neurophysiologic and neuroanatomic dissociation occurs. And again, it's pretty much everything other than the recording electrode is the same as your upper extremity SSCPs. Now, sometimes the surgeon doesn't want to map sensory motor to see doesn't want to use the phase reversal technique specifically to see a phase reversal. Sometimes a surgeon just wants to know he's far enough from the motor cortex that he's safe. So for example, here was a case where we got nothing but sensory responses. And the surgeon was okay with that because he wasn't looking for the reversal. So these are all the other little caveats that you have to understand when you're doing any type of phase reversal technique. You might not always be looking for an actual phase reversal. So sometimes, like I said, the surgeon's happy with just getting sensory because he knows he's farther away from the motor cortex. There are times, however, when he puts the strip down where he thinks is sensory or should be sensory, and you get all motor. Well, in that case, he has to change his operational plan because he obviously does not want to cut into and do a corticectomy into the motor cortex if he can avoid it, obviously. So that's important. So if you see all motor, then you want to look for that reversal, find where sensory is, stay away, so they can stay away from it. So the sensory motor localization, it uses the amplifier, it's an acquisition, it uses pods, or however you're setting up your OR table with whatever instrumentation, neuromonitoring machines you use. Now, the reason for the phase reversal is still not fully understood. However, it is postulated that sensory impulses from the thalamus are being sent to the posterior wall of the central sulcus, and that neurons within the prerolandic area are generators of the P22 response. So the P22 response being that motor response. or that mirror image response. It's not a motor response in the sense of a motor potential. It's a mirrored image response of the sensory over the motor cortex. Also, association fibers from Brodmann's area 3B may influence the generation of the P22. However, it's most likely direct projections from the thalamus to the motor cortex eliciting this response. So here's the thalamus to the motor cortex in this thalamocortical loop. Now, it could also be that the postcentral area, right, so sensory, is electronegative in nature when evaluating the median SSCP, whereas the precentral area is electropositive in nature. So the motor's area is electropositive in nature, causing a reverse in the polarity, and this is due to the axis being a dipole. So what's going to happen is they're going to do a craniotomy, and the craniotomy is the removal of the skull, right, the bone. Once they open the bone, they're going to open the dura. Once they open the dura, this is usually when the surgeon will place the strip electrode. It's going to go subdurally, so under the dura or on the exposed brain itself. So the first thing that happens is before we even get to this point, I usually like to have the surgical tech give off the strip electrode while they're exposing. That way I can plug into my acquisition pod or my amplifier box, or I guess whatever instrumentation you're using early. It's not at this point that I'm plugging everything in. I have everything plugged in to the box as needed. The strip goes in, and the first thing I do is I have my impedance up so I can check the impedance of the strip electrode. You might have artifact due to brain pulsation if you don't check your impedance, especially depending on the machines that you use. For example, I use Cadwell's, and I have no affiliation with Cadwell other than I'm a user of Cadwell, and I know if I don't check an impedance, sometimes we can't get good responses. So we check the impedance, make sure all of our contacts that we've assigned are green, and then we're good to go. Now, if the impedance is poor, there's a couple of things that you can do. Number one, if it's poor across the entire electrode, you can try repositioning the electrode. Or if it's poor amongst, you need at least 4 channels to do a phase reversal technique. So if you're doing I typically use 1x6 strips or 1x8 strips. I don't really use grids a whole lot. You can use grid electrodes, but if you have at least 4 channels, then you can do the phase reversal technique. Now, if you don't have enough electrodes to do the phase reversal because of poor impedance, so let's say 5 out of your 6 electrodes are poor, you can reposition the electrode. Sometimes when these electrodes are placed over necrotic tissue or veins or tumor itself, you get bad impedance. So try repositioning the electrode. You can also try irrigating the surface of the brain with warm saline. If you can't get a good impedance at all from any of the electrodes or most of your electrodes, change the electrode out. And if you are able to have enough channels to at least do a phase reversal, so meaning that you're doing a 1x8 strip electrode, but 4 of your channels are giving you good impedance and 4 aren't, well, disable the 4 that you're not using that don't have good impedance and see what you get from the strip with the remaining electrodes that are working and giving you a good impedance. So this is a video of my surgeon placing the strip. So what happened here is, and I will first we put the electrode over where he wants to do a corsectomy, which is going to be right over here. He wants to ensure there's no motor or sensory going on here. So we can do a clean corsectomy and get to the tumor. Once we know whether or not there's motor cortex here, he'll then place the strip away from his surgical site, but towards motor, so we can do continuous monitoring of motor potentials, which I'm going to get into when we talk about direct cortical stim. But this is my surgeon again placing the strip electrode subdurally, close enough to his field where we can monitor appropriately, but we know this area is safe because we already mapped it. So these are a couple of ways to set up. So this was, in this case here, you can see a huge tumor infiltrating towards the motor cortex on the posterior side. So what we did was we laid the strip along where this is right over the tumor to try and find a safe zone so they can get in to do a corticectomy and get in and remove this tumor. And they were basically coming front to back. So what they wanted to do is make sure there was no eloquent motor cortex, primary motor cortex here. So we laid the strip over where the tumor was, and we mapped it appropriately. This is just showing a couple of electrodes. This is an epilepsy case. We're using multiple electrodes to do phase reversals and record also. These are grid electrodes and strip electrodes for doing phase reversals and for recording electrocorticography, and which is EEG directly off the brain for seizure focus. So settings for the phase reversal technique. Like I said earlier, it's just an SSEP recorded directly off the brain. You're replacing your C3 or C4 electrode with this strip electrode or grid electrode. Stimulus is delivered at the median nerve at the wrist, and then the strip electrode is then referenced to FZ, just like you would do your C3 or C4 if you're using a C3 to C4, a C3 to FZ montage, for example. Stimulus intensity is, whatever you're using for your median nerve stimulation in your typical cases, you're going to use in this case. Your sweeps, anywhere between 200 and 1,000 trials, and to be honest with you, these are robust, big responses. So you typically don't need 1,000 trials, especially in a clean electrical room. If you're getting a lot of noise issues, that's different. But typically, these come in very, very fast. Because, like I said, you're recording SSEP directly off the brain. You're not going through skull. You're not going through skin. You're directly on the brain. So it's nice, big responses, typically. Your duration is going to be, 200 to 300 microseconds, whatever your rep rate is that you use for your typical SSEP setup. Now, I will tell you, one of the tables that we use, and this could be very specific to my hospital, but I will share it with you guys. So if you do run into this, I typically ask the anesthesiologist to unplug the table completely prior to running a phase reversal technique at all. Because for whatever reason in the room that I'm in, when that bed is plugged in, there is a ton of 60 cycle noise, and it will overtake your SSCP recording. And you don't see it as much on the traditional scalp SSCPs, but for whatever reason, when we put the strip in, it really engulfs it. So the first thing I do is right when they're putting the strip in, I'll ask the anesthesiologist, would you mind unplugging the bed? I don't have them turn off the bed, because if they just turn off the bed and keep it plugged in, the bed maintains an electrical charge. So we have them unplug the bed completely, and then obviously once we're done with the phase reversal, they can plug it right back in. So, and when you're doing your mapping for phase reversal, they're not typically moving the bed up and down, so it's okay. And most beds run on battery anyway, so it's not the end of the world, by unplugging the bed here. So just a little food for thought. If you're getting a lot of 60 cycle noise in your phase reversals, just try unplugging the bed and you'll be amazed. And again, like I said earlier, we reference to FZ. However, you're going to probably have to lateralize your electrode in order to get access to the head, because of where the craniotomies typically are in these cases and the incision sites. You do want to make sure your settings are correct. And again, use your SSEP as a pilot for your phase reversal. So this was done by somebody that I know that was a little inexperienced, unfortunately, in doing a phase reversal, and they weren't looking at the SSCP as a pilot, and they were calling whatever this is, because I think this is 20 milliseconds right here. So this is where your N20 should be. And they were calling this all sensory. Now, there's multiple problems with this. Number one, the time base is wrong. This should really be 5 milliseconds per division, not 10 milliseconds, because you're seeing a lot of erroneous information at 10 milliseconds. Number two, the phase reversal, the SSEP response from the strip should not come in at 20 milliseconds if your pilot SSEP, your scalp SSEP, is coming in at 27 milliseconds. And if we look at where 27 milliseconds is, this is also not a response. You can see this is the same exact response as here, 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 here. This is 60 cycle noise that we're seeing. So what this person was calling a all sensory was unfortunately bad for the surgeon, for the patient, et cetera, because you're giving false information. We don't know where the sensory motor cortex is in this specific case because we don't have good data. So make sure your settings are correct and make sure you're following your pilot. I always place a marker on my phase reversal screen, my window. I like looking at so wherever my SSEP cortical falls, I will put the marker at the same time base on my waveform window, and usually that's where the SCP from the strip comes in, or close to it, close enough. Also, just tell the surgeons what's on your screen. There are times when you're doing big setups, big grids, big, and it might not make sense to what they're looking at. So just tell them what you have. Contacts 1 and 2 have a sensory. Contact 3 has nothing. Contact 4 has a blunted sensory response, so on and so forth. Sometimes this could have been due to the contact 3 being on a vein, for example, and just getting a bad response, or it's on tumor for all that matter. We might be spreading the tumor here. So you just tell them what you see, and if this is set up correctly from a setting standpoint, it's not going to lie. So now let's switch gears and talk about direct cortical stimulation. Now, direct cortical stimulation is one of the oldest intraoperative neurophysiological techniques that we still use today. It was first described by Fritz and Hitzig in 1870. Penfield and Bouldry, they made a standard of practice when they published their case series on awake patients being stimulated while they were undergoing craniotomy to map eloquent areas of the brain. That was in 1937. We still use the Penfield technique. It's a different there's basically two different mapping techniques, which I'll talk about. In the 1990s, we started applying multipulse stimulation, and we were able to do direct cortical stim in patients that were anesthetized. And really, that was the precursor of transcranial motors. So we started with direct cortical motor potentials, which then translated into transcranial motor potentials later on. So there are two different types of motor mapping. There's the Penfield technique, which is a bipolar stimulation, common in awake craniotomies. This is showing you with the Ojimin stimulator. It's still used today. It's used for language mapping. It's very, very good at language mapping. It's a it's a bipolar technique. Unfortunately, with the bipolar technique, you need more current and you need more time. So you have to leave the stimulation on the brain for 2 to 4 seconds to elicit a response. It works when we elicit speech aphasias in awake craniotomies, but it doesn't really work so well in asleep patients that you're looking for a quick motor potential. These are long, the bipolar is a long train, a 60 hertz train, low frequency, motor stimulation that for 2 to 4 seconds. And you keep the stimulation on for upwards of 4 seconds and get a response. The other stimulation is the Taniguchi method, which is essentially anodal monopolar stimulation. And it's used for patients that are under general anesthesia. And what's nice about the anodal stimulation is that it hyperpolarizes motor dendrites, activating corticospinal volleys much easier and faster in anesthetized patients, as opposed to the bipolar, which needs more current. Also, one of the limitations to using that prolonged 60 hertz stimulation is that it has a higher incidence of seizures as opposed to the Taniguchi method, which is a high frequency, short multi-pulse stimulation. What's nice about both these techniques is that you can differentiate between motor and sensory cortices. You can map the motor homunculus. You can elicit speech aphasias to map language areas. With the Taniguchi method, you can monitor the functional integrity of the pyramidal tracts, as well as perfusion to the motor cortex, which I'm going to get into. However, there really aren't any guidelines specifically for direct cortical stim. ACNS does not have a guideline for direct cortical stimulation. The ASNM discusses direct cortical stimulation in their motor potential position statement. They review all prior studies for DCS parameters, but they don't give definitive guidance on what current should be used, what pulse width should be used, what ISI should be used. So we need to defer to the literature to find out these things. So we talk about direct cortical stimulation in anesthetized patients. It's very, very similar. When we're talking about the Taniguchi method, it's very similar to transcranial motor potentials. So this cartoon shows you how we do multipulse stimulation in a anesthetized patient because we have to prime that alpha motor neuron because the anesthesia inhibits at the alpha motor neuron. So we want to activate it by priming the anterior horn cell. So much like transcranial motor potentials, direct cortical stimulation is best achieved using anodal stimulation. Anodal stimulation does not penetrate as deeply as cathodal stimulation. In principle, it's much like a transcranial motor potential. However, the stimulus is delivered directly to the brain surface. And like a transcranial motor, a compound muscle action potential is elicited from different musculature where EMG electrodes have been placed. However, the literature describes going up to 30 milliamps safely if you're going to use constant current, or up to 120 volts safely if you're going to use voltage stimulation. You can use a strip electrode, a monopolar, handheld, flush tip electrode, a ball tip electrode if it's small enough for a bipolar electrode. You can use as well. So DCS is similar to transcranial motor potentials. Use contralateral muscles in the face, the upper extremities and lower extremities. You can then tailor your mapping and monitoring after reviewing the MRI with a surgeon to add specificity to your mapping and monitoring. Stimulus intensity, like I said, up to 30 milliamps. That's what the literature says is safe if you're using constant current. I'm a fan of constant current. But you can also use voltage up to 120 volts. Your pulse train, I usually have a pulse train set up of five pulses. My ISI is typically 2 milliseconds, but you can adjust that. You go up to 4 milliseconds, or down for that matter if you need to. Your duration, if you're using constant voltage, then you're going to do a 50 microsecond pulse width. You're not going to go higher than that because you don't want to penetrate deeper structures. You want to stay as superficial as possible. And if you're doing constant current, you can do a 500 microsecond duration. And again, because you're stimulating so much lower with the constant current, you need a higher duration. The strip or probe are plugged into the anode. And then you have separate cathodes that there's two ways to do this. You can either use an off-site cathode, or you can reference from one contact of the strip to another contact of the strip. So you can do, for example, you can make 1 your anode and 3 your cathode, 2 and 4, so on and so forth. I don't do that. I have I get great responses by putting an off-site return and then making each contact of the strip their own individual stimulation channel, which I'm going to show you about. I put multiple off-site returns in, and I'll show you, how I do that. Basically, I'll start my stimulus off the strip with whichever contact gave me the motor cortex in the phase reversal. So if the phase reversal said contact 3 started my motor area where 1 and 2 were sensory, well, I'm going to start with contact number 3 as my motor stimulation, and then go from there. And then I'll dial through each contact and see where I get the best and most reliable responses. Cold saline should be on the field prior to any kind of direct cortical stimulation, as you can elicit a seizure by using direct cortical stimulation. It's rare when you're doing the Taniguchi method. Higher instances, like I said, in bipolar stimulation, long train stimulation versus the Taniguchi, multipulse stimulation. But you should still have it, because if you do have a seizure, the cold saline can eliminate it immediately. The literature says you need at least 10 milliamps to activate the cortical spinal tracts with direct cortical stimulation in an anesthetized patient. However, I usually start about 12 to 15 milliamps, and then I go up and down from there. And I've gone down as low as 4 milliamps in an anesthetized patient. All depends how they're reacting to the anesthesia, obviously. So yes, the literature says that 10 milliamps is the typical threshold, but there are times where you can go lower and still get robust responses from the direct cortical stim. What's nice about direct cortical stimulation is that there's no movement with the patient, so you can do it if they leave the strip on the brain while they're doing their resection or their dissection for the aneurysm, for example. You can continuously monitor a motor evoke potential and have direct information about motor function in real time every second, versus a transcranial motor, which you can only run intermittently. So there's a lot of benefits to getting a strip placed in craniotomies, and I try to get all of the surgeons I work with, whenever there's a chance the cortical spinal tracts are at risk, to place an electrode in order to run direct cortical motors. So to map the motor cortex effectively, it's suggested that once the phase reversal technique is conducted and the motor strip is identified, the surgeon should rotate the electrode so it's parallel to the central sulcus over the motor strip. This will allow you to map the motor homunculus. And this is beneficial specifically in epilepsy surgery. May not be needed so much in tumor resection, because if the tumor, for example, is over here, just knowing where the motor cortex is sometimes is enough. And also, if you're just leaving your strip as is, and you're able to get at least the motor off of one of the contacts on the strip, then that gives you enough information of the cortical spinal tracts during the procedure. But it's not bad habit to get the surgeon to turn and put it parallel with the central sulcus if they can. Again, like I said, surgeons sometimes just want to know where the motor strip is in order to avoid it. This was a case that I did many, many years ago down in New Orleans, where it was an epilepsy surgery. We mapped the sensory cortex, we mapped the motor cortex, and then we found the central sulcus, and then we did mapping with a monopolar flush tip electrode, and we found the face, the arm, and the hand. What was interesting about this is that this patient was wired differently than most of us. Where it should be face, hand, arm, this patient was face, arm, hand. And this was after mapping. I think we mapped this patient for over 2 hours, constantly stimulating the same areas just to get true positive responses, the surgeon was the one that put these little markers down to know where he was and what he could, where he can do corticectomies and where he could do subpeals for this for these seizures. But this is a very interesting case because it just shows that we're all wired differently. What is in your classical anatomy textbook, where it's face, hands, arms, this patient was face, arms, hand. It's just how this patient was wired. So when you're talking about target muscles for your direct cortical stimulation, you're going to want to target, the contralateral side of the body to where you're going to map and monitor for that matter. What we do is we focus on the contralateral, then we have ipsilateral controls. So what we do is we'll do contralateral face, we'll do the oris and mentalis, and then we'll do the tongue. We do the lower face because of the true crossover in the cortical bulbar tracts for the lower face versus the upper face, which gets ipsilateral contribution as well. So we do, and plus we have limited channels, so we'll do the lower face contralateral, we'll do the tongue, we'll lateralize the tongue the best that we can, and then we'll do a shoulder, we'll do a biceps triceps, we'll do a flexor extensor, and then we'll do 2 intrinsic hand muscles. Lower extremities, we'll do a quadriceps, we'll do a TA and a gastroc, we'll do an extensor digitorum brevis and an hallucis longus. And then that's on the contralateral side, that's our target, that's our focus, and then we'll have controls in the hands and feet of the ipsilateral side. This was just a seizure case that we were mapping, and we found the hand area and we found the orofacial area with the tongue. We turned off the face in this because it was just being inundated with noise artifact, but we were able to get a nice tongue response from direct cortical stim, and then isolated hand response. And this was exactly where the surgeon thought these should be. And this wasn't a tumor, this was epilepsy. So we wanted to make sure that we were, he was in the area he thought he was in. Setup is super important in these cases. Now, for those of you that have not been in craniotomies, it's a little hard to picture in your head, but what they do is they turn the bed. Depending on the room you're in, they might turn it 90 degrees, they might turn it 180 degrees. You have to have an idea of where they're turning the bed before you can set up your bed. It's not like when you're walking to a lumbar surgery and the bed, you can set up the bed nice and early, and nothing's going to change unless they decide that they have the wrong bed, and then that's a whole different situation that we've all been in. In this situation, they're not going to move the bed until the patient is positioned, intubated, is on the table and intubated, and then they're gonna rotate the bed. So what I do and what I train all my staff to do is to be as proactive as possible. Always move without the ball. Get whatever you can get done while you can, because there's a lot of get in and get out. There's a lot of times where you can get to the patient, do what you have to do, then you have to step back, let the surgeons or the anesthesiologist do what they have to do. So in order to mitigate any hiccups, we try to be as proactive and as diligent as possible when doing our setups. So like I said, we use Cadwells. So we'll set up all our pods early, and you see how we have all of our needles plugged in here. What we'll do is we'll take these wrapped up nice and neatly, we'll bring them to the operating room table, we'll leave them wrapped up like this, we'll place the electrodes in the patient, and as soon as once they turn the bed, we'll unroll these back to our cart, our machine. So we try to keep it as neat as possible. There's a lot going on in craniotomies and positioning, and every case gets positioned differently. Some are supine, some are direct laterals. So all of this has to be taken into account when you're doing your setup. So if you keep it as neat as possible, and I'm not telling you, like, this works for me, you have to figure out what works best for you, but just keep in mind they are going to move that bed. I always set up my stimulation boxes and my phase reversal acquisition pod opposite wherever the surgical field is, because you have to be able to get to those boxes, right? They're going to drop the strip off or they're going to drop the probe off. You have to be able to get to those boxes or pods to plug in. And if you put it on the side where the surgical field is, you're not going to be able to get in because the surgical field is there. They have to move it for you. It really becomes painful. So there's usually opening on the side opposite the surgical tech. So if, for example, it's a left-sided craniotomy, and the surgical team is on the left side, I'm going to put my stim boxes and my pod for the phase reversal on the right side of the bed, so I have access to it. Another thing, and it depends on your surgeon, typically you wait until they mark the surgical incision site before you place your electrodes in the scalp. And the reason for that is because you have to know where you can go and where you can't go. They're going to, surgeons are going to dictate where you can place electrodes, and a lot of times where their incisions are right where we need to be as well. So sometimes we have to, call an audible and think outside the box a little bit on how to, put your headset leads in. Now, I have one surgeon that wants us to put it in prior to him doing anything. So we just, we've been working with him long enough. We know where he does his incisions, and we have a good idea, and we can always move electrodes around. But most surgeons will wait till they mark it. Then you get in there and you place your electrodes. So this I want to show you because I want to show you how I set up for my direct cortical stimulation. So this is a picture from a wake craniotomy that we did. Motor, and I'm going to go over a case study with this a little later in this lecture. But the point here is I use off-site returns, and I use enough for the amount of channels that I want to basically analyze from the strip electrode. So in this case, we were using, in the case itself, we ended up using a 1x4 strip electrode, but we had it set up for a 1x6 strip. So we have a 1x6 strip here, and then we have 6 off-site returns, and I have basically 6 channels in a stimulation box set up specifically for every single anode from the strip and then the cathode from the that I place on the scalp off-site. Now, off-site meaning I usually put it in the contralateral skull base to where they're working. So if they're doing a left-sided craniotomy, you see this is the right-sided contralateral side away from where they're working. And you just put a cluster of electrodes together. They can even be closer together than this. I use all corkscrews in all my craniotomies. And basically, all of these are my negatives. They get plugged in, and then when the strip gets put off the field by the surgical tech, then I plug them into the positives. And then I have each one has an individual channel, which I can then dial through on my catapult machine. And I'm sure most machines has the ability to do this. You just have to set it up so you have enough anode and cathodes. Because until we're able to have one anode or one cathode linked to multiple anodes, I have to do it this way, kind of a poor man's version of dialing through each channel. So basically, I'm able to go into the software and then dial through, go to channel 1, stimulate, channel 2, stimulate, channel 3, stimulate, channel 4, stimulate, without ever having to leave my station. Back when I first started doing this, 15 years ago, we didn't have the ability to do this. We didn't have the ability to have this many stimulation channels. So we had to actually we had one offsite return plugged into one channel, and then we'd have to go up to the field and plug in 1, plug in 2, unplug 2, plug in 3 to the same channel, and you'd unplug 1, plug in 2, go back to your station, hit a motor. If you don't get something, you go back, unplug 2, plug in 3. That gets a little tiresome, so to speak. So now, with the advent of more channels, and I always have, for all my cases, 2 stimulation boxes. So I have one stimulation box that's just for my SSEP stimulations. This box is just focused on stimulation for direct cortical stimulation. and subcortical as well, which I'm not going to get into in this talk because we're talking about cortical mapping, but I do have a setup on my boxes for subcortical as well. The only difference between a cortical and subcortical is you reverse and you do cathodal stimulation versus anodal stimulation. Again, you can see the strip electrode is going into the positives or the anodes, and then the offsite returns are going into the negatives or the cathodes. And just also want to show you here, here's my we're going to do SCPs in this case as well. So we have we have the FZ here, but you can see it's off-centered. It's not true FZ because they have the navigation here, and they're going to pin the head here. So we place it a little off, center, and still kind of an electrically silent area, so we're able to get a clean phase reversal and SCP for that matter. What's nice about direct cortical stimulation is once you've mapped the area, let's say you've dialed through all of your channels and channel 5 gives you the most robust response, you can leave the strip in there. You can stimulate from contact 5 for the rest of the procedure. The patient won't move, and you can do upwards of 255 motors, such as this case here. So it has such a benefit. But again, you have to make sure that the patient's not moving. I watch the microscope. I usually have the microscope plugged into my computer so I can watch it right on my screen. Because sometimes at higher, if they're not directly on motor and you're getting some premotor at higher stimulation intensities, you might get a little bit of patient movement. So you got to be careful with that. But typically, you don't get patient movement at all. So it's a very nice advantage to doing direct cortical motors that there's limited movement. You can run them as often as necessary, even because you got to realize that there's excessive cautery in these procedures. So if you're just doing SCPs or transcranial motors and that's all you're doing, you're going to have very intermittent monitoring versus real time, like a case like this. So we'll go through a couple of case studies. Here was a bifrontal craniotomy for the resection of an intrahemispheric mass. The patient present with marked tremors. They had disorganized behavior times 3 weeks. They had repetitive thoughts. They had passive suicidal thoughts. They were incontinent. They had changes in behavior. They were urinating on the rug. The patient was high functioning at baseline. They were alert and oriented. They had no relevant past medical history, and they and they did have a knee surgery. So you can see they have this bicoronal mass. So we get in there and we find that where the strip is completely over all motor, which is okay. The surgeon was okay with that. So we were able to elicit a direct cortical motor, and this was before I changed over from voltage to current. I use pretty much strictly constant current now, but in here I was using my MEP box and doing a constant voltage. And you see we have this nice foot MEP. We didn't get anything else. And in this case, if we go back and look at the MRI, well, that makes sense because they placed the strip very medial, so we were kind of over the leg area, the foot area, which is why we're only getting the foot here, and that's it. And the surgeon was okay with that because that's what he wanted. He just wanted to monitor. He wasn't really interested in the mapping portion of this. He just wanted to make sure that where he was working near was intact and safe. So in this case, we were able to do 255 direct cortical motors as opposed to 23 SSCPs of the lower extremities. So you can see how valuable those motors can be. Another case, this was a frontal parietal tumor, 54-year-old male. They had new onset seizures in July of 2018. Initially evaluated in Detroit, where they were found to have a left frontal parietal lesion. They had a subtotal resection in Detroit. Then decided it was a grade 3 glioma. They decided to travel to New York City for an awake craniotomy with my surgeon, and we had a repeat resection with neuromonitoring, and the patient came in neurologically intact. So here's the tumor. Here's what was left over from there from the subtotal resection. So the modalities that we performed, we did SSEPs. Now the patient was awake, so we really used the SSEP as a pilot for the phase reversal. We did a phase reversal technique. We did EMG for fine motor movement. Again, the patient's awake, but we wanted to see, if they started, kind of moving some hand muscles, we'd be able to see it with the EMG. We did direct cortical stimulation with a flush tip probe, and this was not a language mapping case. So we did direct cortical stim using Taniguchi technique on the awake patient, and we also ran an EEG as well. We did not do transcranial motor potentials because this patient was awake. So we didn't want to elicit high voltage stimulation into the patient that was awake because we weren't able to get a bite block in, etc. Again, this case was not for language mapping, but there was qualitative observation of gross motor movement performed by a neuropsychologist, and this was independent to our monitoring. So next to the patient, the neuropsychologist would ask the patient to, move their arms, squeeze their hands, and also talk to them as well. And then we were kind of looking under the microscope, so to speak, with the neurophysiological, electrophysiology. So, why are the SCPs noisy? Well, this patient's awake. That's why the SCPs are noisy. And you can see the SCP is defined here in the upper extremities. Bed in the lower extremity is not well defined. A little something there, but they're noisy because the patient's awake. We're stimulating them at 5 milliamps, just to give you an idea of how low we were stimulating. So we were intermittently running SCPs throughout the procedure. We were watching the EMG and the EEG during the resection along the posterior border of the tumor. So they got back to the back end. So here, this is the motor cortex here, right there. So they got to the back edge of the tumor, and the patient went into upper extremity motor arrest. So they couldn't move their arm. They turned to the neuropsychologist and said, "I can't move my arm." Surgical pause allowed for motor function to restore to the right upper extremity, but the proximal arm remained weaker than the hand, so they couldn't really move their arm up or move their shoulder, but they were able to start moving their hand again. And we actually saw it in the EMG come back first. We were able to tell them, hey, he's starting to get some muscle movement in his hand, even though they couldn't see it. And then finally he was able to move his hand, which was very, very cool that we saw that so finally with the EMG. The resection resumed until another episode of motor arrest occurred, but this time in the lower extremity. So the upper extremity is still weak, and now the patient can't move their leg. And they're telling the surgeon and the neuropsychologist, "I can't move my leg." So the surgeon decides, well, I'm going to map the area now. I've gotten to the posterior border. I want to see how close I am to the motor cortex. And this case is kind of done backwards. So when you read about weight craniotomies and motor mapping, you usually do the motor mapping first. The reason why we didn't do the motor mapping first in this case is because the patient had a subtotal resection already. So they already knew where the margins of the tumor were. So it wasn't until we got to this posterior border where we kind of know where the motor cortex is, but we're not 100% sure at this point. That's when they decided to map, because now the patient was having clinical findings. So we put a 1x4 strip electrode in, and we do the phase reversal technique. And as you can see, contacts 1 and 2 are sensory, contacts 3 and 4 are motor. This is, again, noisy. The patient is awake, but we knew where motor was. Now, surgeon, we took a fine tip, flush tip electrode, a handheld monopole electrode, and at 2 milliamps, stimulating the motor cortex, and we were able to find the hand. So we found the hand. So next, the surgeon started tracking the homunculus medially, to hand to now we're getting the forearm and the upper arm and the shoulder. Now we're just seeing EMG activity superimposed in our motor potential window, because the patient's kind of squeezing their arm hand a bit while we're working, and they're kind of moving around just in general. They're awake. They're not feeling the stimulation, but they're they are awake, so they are moving. And then we tracked it more medially, and we were able to elicit lower extremities. So we got the quad, the tibant, the gastroc, Nemeus, the extensor brevis, and the AHL. And again, this is just showing you that this these are not motor responses in the hand muscles. This is the EMG that we saw at that same time. Again, patients just kind of moving around so we're able to track the and show continuity of the motor cortex. So what was nice about this case, and we actually published this as a case study, so if anybody's interested in that, please contact me. I'll send you the paper. They were able to do a 95% resection. This is what was left over. 95% resection of this. The patient woke up weak. However, because we showed continuity of the motor cortex, we knew, we were confident this was going to be transient, and within a week the patient was back to normal. So that was a good sign, where the electrical mapping was able to give information regarding the prognostic level of this patient and how they were going to do, because we had continuity of the motor cortex. So their motor arrest in their leg was transient and not an injury to the motor cortex directly. And I'm going to leave you with this case study. This is a 65-year-old. So this is going from, we talked about 2 tumors. Now we're going to talk about cerebral vascular surgery. This is a 65-year-old female with a right MCA aneurysm. We did SCPs, transcranial motors, direct cortical motors, EEG. For a transcranial motor, we had a train of 6, a pulse with a 50 microseconds, ISI of 2, and we had voltage between 100 and 300 volts. For direct cortical motors, we had a train of 5, a pulse with 500 microseconds, ISI of 2 milliseconds, and a constant current of 15 milliamps. Again, target muscles, same that I showed you earlier. We do the oris mentalis, the tongue, the deltoids, the biceps, triceps, the flexor carpi radialis, the extensor digitorum communis, the APB and the ADQM, quadriceps, the tibiant, the gastrocnemius, the EDB, and the AHL. And again, there's the contralateral to where the aneurysm is, which is the MCA aneurysm. They do a pteroneal approach to the aneurysm for the craniotomy. Once the dermata was peeled back, the aneurysm located. Well, actually, not before it was located. Once the dermata was peeled back, and they put a 1x6 strip electrode, and then dissected down to the aneurysm. Again, showing you the multiple contacts for constant current simulation. So in this case, we don't do phase reversals typically in our aneurysms, because we're not mapping, we're not looking for motor sensory. The only time we do a phase reversal is if for whatever reason we're not getting a motor response at all from initial stimulation. So we go right from the strip into the stimulation box. So I put all 6 contacts from the strip into the anodes. I have my 6 offsite returned, and then I dial through. And in this case, contact 2. So contact 2 gave us the most reliable, most robust responses for direct cortical motor. And in this case, so here's a waterfall, just looking from the beginning of the case, or the beginning of when we had the strip in to the end of the case. You can see we actually get very nice motor potentials from all of the muscles that we've targeted. So, and for cerebrovascular cases, is exactly what you want to get, because you have, if you're doing MCA and you lose your upper extremities and you still have your lower extremities, well, you know that that's most likely a real thing happening, versus if you only have upper extremities and you don't have anything else to go by other than your SCPs and potentially transcranial motors. So in this case, during the first temporary clip, everything was stable. The second clip on, we started having a degradation in our upper extremity motors, where our lower extremity motors never deviated. Clip came off, response came back. Clip went back on, response went away. Clip, they put the permanent clip quickly across the neck of the aneurysm, got temporary clips off, and we were able to come back to baseline by the end of the case. So you can see it's very, very powerful with regards to this direct cortical, motor potential is very powerful with regards to, perfusion when blood supply is lost to the brain. However, in this case, we were also running transcranial motors, and at the same time, no change at all to the upper extremity transcranial motors. So this is most likely because the transcranial motors are penetrating deeper than what we're in the structures that are at risk. This is an important thing to understand when you're monitoring craniotomy, especially when you're doing motors, and if you're only doing transcranial motors and not direct cortical motors. Direct cortical motors are going to be more superficial. They're going to be very focal and more specific, where transcranial motors uh, tend to not be as specific. It might be too sensitive at times. And again, we're taught to control for this crossover response, which I'm going to talk about. But you can see here, the crossover response doesn't occur, and we still have a motor potential that hasn't changed. So if we're only doing motors in this case, direct transcranial motors, we probably would have seen the change in the SSCP. We didn't run the SSCP because we had the change in the direct cortical here. But if you're only doing transcranial motors, we would have missed it, and the patient would have potentially had a devastating injury. So let's talk about the crossover response a little bit. It's suggested that when conducting transcranial motors during supratentorial craniotomy, that the neurophysiologist controls for the crossover response. So what this is based on is the hypothesis that a crossover response occurs when the activation of the motor tracts is occurring deeper than the structures that are monitored. So transcranial motor potentials and direct cortical, motor potentials are part of our armamentarium and should be used accordingly. Direct cortical motors are shown to be more specific, more sensitive than transcranial motors in supratentorial craniotomies and should be employed when feasible. However, you don't want to discard transcranial motor potentials or discontinue their use at all, even though you might bypass, even with controlling for the crossover, you might still bypass structures at risk because of you can't control the steering of the current when you're doing stimulation with motor potentials, right? So, but they still have benefits. For example, they can establish your baseline data, so you know that you should get a motor potential at all from the strip, by similar to getting a phase reversal and having pilot SSCPs. But what you have to understand is there has to be expectations of their utility. You need to manage that with the surgeon as an indicator of cortical function. Because if you're only using transcranial motor potentials, it has to be understood by you and by the surgeon that the risk of a false negative occurring is exponentially increased, even if you've controlled for that crossover response. So it's super important that if you're going to do motor potentials in any kind of craniotomy that you can get a strip in, you can try to get that strip in. If not, just because you're getting a motor potential without a crossover doesn't necessarily mean that you're not penetrating deeper than structures that are at risk. I'm going to leave you guys on that. Thank you very much. If you have any questions, here's my contact info. Please feel free to contact me. This is me working in a craniotomy. We have in our hospital that we do most of our craniotomies, we have an exoscope, so we wear these 3D glasses so we can watch the exoscope, and it's actually pretty cool. But like I said, feel free to contact me and enjoy the rest of the conference.
Hi, my name is Dr. Eric Chang. I'm in pain management, sports medicine, rehabilitation, and regenerative medicine. I'm here to talk about surgical solutions and review what's new. My lecture goals. We're going to go over reviewing current modalities used for pain assessment, evaluate the importance of documentation of pain management, summarize how a patient's perception of their pain management affects care, examine the pharmacological pain treatments and the importance of multidisciplinary team and patient relationships in lieu of surgery, and how we work them up for surgery. So what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. It's described by the International Association for the Study of Pain, IASP, which is the definitive society for pain management. So the significance of pain is the number one reason people miss work in the US. It costs greater than $100 billion per year in direct medical costs, lost income, and productivity. And JCAHO has declared it as the fifth vital sign, where the patient has a right to adequate pain control. So The reason people go see a provider is that they are in pain, either have a cold or a broken spine or radiculopathy. Most patients self-treat pain, and in primary care, providers see more patients with back pain than any subspecialists, such as orthopedic specialists and neurosurgeons combined. So the classifications of pain, and acute pain is less than 3 months, chronic pain is longer than 3 months. Acute pain is a natural physiological response to injury. It warns individuals of disease or harmful situations, and it's less than 3 months in time period. Chronic pain may or may not be related to a disease process, and the pain, it's classified as pain that persists beyond the expected time of healing. And it's usually more than 3 to 6 months in time. So there are generally the two or three types of pain. There's nociception, described somatic and as visceral, and neuropathic neurogenic pain, which is central or peripheral mediated, and there's a mixed combination of nociceptive and neuropathic. For example, nociceptive, if someone takes some baseball bat and hits you, you'll feel the muscle pain, the cramping, bone and joint pain, knee pain, osteoarthritis pain, ligament pain, soft tissue injury. It's usually associated with pathological damage, such as in the tissue structure, and it's in lieu of a normal nervous system. Descriptive words are important because it can help you differentiate between nociceptive and neuropathic pain. So words such as dull, cramping, achy, sharp, and stabbing are descriptive terms for nociceptive pain. Neuropathic pain, on the other hand, is nerve-related pain. It's a dysfunction of the physiological nervous system. Examples such are diabetic neuropathy, postherpetic neuralgia, lumbar radiculopathy, quote unquote sciatica, or spinal stenosis. Descriptive terms for neuropathic pain include lancinating, burning, electrical, tingling, numbness, pins and needles. Conditions that are in the realm of neuropathic pain are carpal tunnel syndrome, entrapment of the median nerve, neurogenic claudication, or spinal stenosis, or conditions such as postherpetic neuralgia and diabetic peripheral neuropathy. There are barriers to pain management or seeing a provider, such as fear of adverse events, cognitive impairment, fear of loss of independence, fear of addiction, fear of tolerance, resources to pay for analgesia, or comorbidities. The description of tolerance is a state of adaptation. It's exposure to a drug that results in diminution of one or more of the drug's effects over time. Addiction is a social economic term, such as it affects the neurobiological disease and is characterized by one or more impaired control over drug use, compulsive use, continued use despite harm, and craving. Pseudo-addiction is a term where a person has drug-seeking behaviors, but it is relieved after you treat their pain adequately. For practitioners, the barriers for them in prescribing opioids or medications is a lack of knowledge of non-pharmacological approaches to pain, fear of opioid toxicity overdose, fear of opioid dependence, and fear of legal scrutiny. Consequences of uncontrolled pain are loss of physical function, increased depression, or greater mood disturbances. So what we do before we decide whether they're a surgical candidate or not is we have to assess the patient. So the patient, unfortunately, is the only reliable source. There is no biomarkers to assess how much pain they're in. We use unidimensional scales, pain scales that must always accompanied by a good H&P exam, and we use the same scales consistently. So these are some of the commonly used pain scales, such as the Wong-Baker-Facey pain rating scale, the numeric pain rate intensity scale, the VAS or visual analog scale. You want to keep the assessment simple. You want to use visual aids, and you want to ask them simple yes and no questions and not open-ended questions. These are some resources online where you can get a lot of information and tools. For assessing pain, you want to understand whether they have visual or central visual or hearing limitations. Patients be given enough time to respond to the questions. Should look for nonverbal pain indicators such as moaning, facial grimaces, bracing, restlessness, or rubbing. If a patient denies pain but has a diagnosis you expect to cause pain, you can rephrase the question. For example, if the patient says they have no pain, you can say, if someone was in your shoes, how much pain would you think they have? And they would be, yeah, I would probably be like 9 out of 10 or 10 out of 10. They might admit to discomfort or aching, but not admit to having pain itself. Assessing pain, you gotta understand guarding, vocalizations, facial expressions, or no muscle twitching. So you have, and even in the before pre-op, you should notice if they're favoring, they have like wrist drop or foot drop. Common pain problems people have. The World Health Organization, the top 3 are back, head, and joint pain. In the US, back pain is the #1 problem. Other common pain issues are myofascial pain, fibromyalgia, and neuropathy. For back pain, the most common causes of back pain are disc pathology or degenerative disc disease, facet arthropathy, myofascial pain, or sacroiliac joint dysfunction. The questions you ask during a history is location, where is the pain? Does it radiate anywhere? Is the onset sudden or insidious? Duration, how long does it last? Is it continuous or intermittent? And as we described earlier, what are descriptive words? Intensity of the pain on a scale 0 to 10. What makes it better and what makes it worse? If it radiates, where does it radiate? For example, is it above or below the knee? Is it anterior, posterior, lateral, medially? Does it go all the way to the big toe, which is the indicative of an L5 dermatome pain, to the heel, which is more of an S1? And it basically, these questions will help you understand what nerve root distribution the pain is in. If you identify red flags are fever, unintentional weight loss, sudden change in pain intensity, bowel and bladder dysfunction, sustained neurological deficits, and if this occurs, it could be indicating serious disorders such as malignancy or spinal infection, and this requires imaging to work up further. Another condition that you see prior to surgery is severe osteoarthritis. It's usually worse in the morning and in cold. What makes it better with activity and heat makes it better is described as aching. Interestingly enough, the severity of the X-ray does not correlate with the symptom severity. And virtually anyone over the age of 65 has evidence on radiologically of osteoarthritis. Myofascial pain, on the other hand, is pain in physiologically abnormal muscles. You have taut bands and trigger points with firm palpation. You have aching, soreness, stabbing, and burning pain. When you evaluate them, you ask them whether they have relief with mild massage, if they have a low level activity, or if they get benefit from heat or cold. Usually the pain is worse with excessive activity. When you physically examine them, you feel a trigger point, which is a knot. It's when you apply pressure for 10 to 50 seconds, you get a local twitch response to your finger or needle. The treatment of that is identifying and modifying perpetuating factors, change your posture, sleep position, body mechanics. Seek early involvement of physical therapists. Aquatherapy is very helpful. Low-level aerobic activity, gentle stretching involving muscles, and trigger point deactivation such as injections. These injections are you locate the trigger point, you usually stabilize it, and you go in with a dry needle. If you have a substance such as lidocaine or bupivacaine with some steroid, that's called wet needling, where you inject a small amount of steroid and sodium channel blocker to relax the muscles, and it's usually similar to an acupuncture technique. Another condition that affects patients' pain complaints are fibromyalgia, multiple tender points, morning stiffness, fatigue. You have non-restorative sleep. I'm sure many of you feel like you have fibromyalgia. It's very common. It's usually signifies that you have some other underlying condition, autoimmune, environmental, infectious. Usually these trigger points, you apply enough pressure to blanch the thumbnail, and the old definition was the presence of 11 or 18 characteristic tendon points. There's a new criteria. Unfortunately, not many people use it since it requires an extensive evaluation and note-taking. You have to use a widespread pain index greater than 7, and also go over a list of symptom severity and score over a 5. Symptoms have to be present at the similar level for at least 3 months, and the patient does not have any other disorder that will explain the pain, such as like if you have a fracture of an arm or leg. Here's the widespread pain index. As you can see, there are multiple number of areas which the patient has had pain over the last week, and the score will be between a 0 and 19. Symptom severity scale, you document fatigue, waking on fresh, cognitive symptoms, and for each of the 3 symptoms above, indicate the level of severity, 0 being no problem and 3 being severe. You can consider somatic symptoms in general and indicate the patient has 0 no symptoms, or number 3 a great deal of symptoms. The symptom severity scale score is the sum of the severity of the 3 symptoms: fatigue, waking, unrefreshed, cognitive symptoms, plus the extent of the severity of the somatic symptoms in general. The final score is between 0 to 12. And again, these are the associated symptoms and complaints. You can see it's numerous. The treatment of fibromyalgia includes aerobic exercise, medications, restoring the sleep hygiene, cognitive behavioral therapy, instructions in flare self-management techniques. For peripheral neuropathy, it's the most common cause in older adults. It's painful diabetic peripheral neuropathy, and reactivation of herpes zoster results in postherpetic neuralgia. Other neuropathies and neuralgias include alcoholic polyneuropathy, chemotherapy-induced polyneuropathy, entrapment neuropathies, post any surgical pain, such as after mastectomy, thoracotomy, amputation. If you have cancer, it can be infiltration of the tumor, post-radiation neuropathy. If you're unfortunate to get trigeminal neuralgia, that's another neuropathy, and also after a stroke. The treatment usually are medications that you see on a patient's list that involve antidepressants, anticonvulsants. They might have had a treatment of TENS unit, spinal cord stimulation, or epidural injection. So what are the treatments of these conditions? 3 principles. You want to do a comprehensive assessment, use of multimodal therapies, non-pharmacologic, pharmacologic, non-opioid adjuvants or opioid, and agent organ-adjusted pharmacology. An effective pain regimen is reducing chronic non-malignant pain by 30 to 50% in pain intensity, while accounting for physical function, mood, endurance, sleep, appetite, interpersonal relationships. Treatment options for back pain before surgery include patient education, exercise, weight loss, physical therapy, interventional technique therapies, pharmacological therapies, psychological therapies, surgical therapies. Here are some patient education brochures. You can get a spine.org or NIH. There is verbal interaction activity recommendations, patient educations, often leads to fewer recurrent problems. So the question about bed rest is usually not recommended. If the patient must rest, it's usually less than 2 days. These are for patients with severe leg pain. Your gradual return to normal activity is more effective than bed rest, and prolonged bed rest greater than 4 days may lead to debilitation. What we do also when we see the patient is initially send them physical therapy. Within the physical therapy modalities is back school, posture, activity, modification, traction, flexibility, and stretching, exercises, aquatic therapy, ultrasound, ice and heat, massage, and TENS unit. Some of the educations includes back exercises. After the patient finishes physical therapy, they're discharged home with a home exercise plan. These include McKinsey exercises, William flexion exercises, an aerobic program such as walking, biking, swimming, and graded exercise fitness quotas. So what is a TENS unit and how does it work? It's usually electrodes that block the pain signals in the dorsal column. It's called a transcutaneous electrical nerve stimulation device, and it activates the large afferent fibers, thus closing the gate in the gate theory of other pain signals coming through the same pathway. Massage appears to be more effective than no treatment at all, and the efficacy of chronic low back pain has not been properly tested or determined. According to Bogduk, a leader in our field, I believe he's a neurosurgeon, he believes that behavioral therapy is better than no treatment and better than placebo for chronic low back pain. It's limited but effective, and it's not, however, it's not more effective than any other active intervention, and is insufficient effective as a primary exclusive intervention. So common medications that you see on a patient's chart before surgery or in the pre-op room is Tylenol, anti-inflammatories, muscle relaxants, antidepressants, anticonvulsants, opioids, and topical treatments. This is the World Health Organization analgesic ladder, where you start with non-opioids, then go to weak opioids, and then go strong opioids and non-opioids, with or with adjuvants. But however, there's a new adaptation of the analgesic ladder where you can essentially start with anything, any step, and go down or up. Step 1 being, again, non-opioid analgesic NSAIDs, weak opioids, strong opioids such as methadone, oral administration, transdermal patch, nerve blocks, epidurals, PCA pumps, neurolytic block therapy, and spinal stimulators. Herbal therapies such as devil's claw, willow bark, capsicum seem to be a safe option, but you want to be aware of when they have back pain, that they're on there before surgery or during surgery, and systemic corticosteroids are not recommended for treatment of low back pain with or without sciatica. So current concepts that you see in pain management or pre-surgical management of patients are a multimodal balanced analgesia. You want to not only give opioids, but other analgesics. You want to work on different pathways, allow synergism rather than forcing just one pathway, and therefore you decrease the risk of medication toxicity. And in addition, you want to focus on preemptive analgesia. So NSAIDs are anti-inflammatories. You see them over the counter. They include Advil, naproxen, meloxicam, which is prescription, diclofenac sodium. Unfortunately, it has severe GI. It erodes the mucosal lining in the stomach, and it causes renal complications. There are approximately 16,000 deaths annually from anti-inflammatory use, as usually works quickly within 4 hours, and there's a delay in the anti-inflammatory pathway, which are days to week. Anti-inflammatories usually, you want to understand their electrolytes and creatinine function, which will tell you the kidney function. You may repeat 1 to 4 weeks. For anti-inflammatories, you start low and go slow, and you consider as needed dosing. Acetaminophen is helpful, and it's usually preferred to anti-inflammatories. But nowadays that we know more of the mechanism, it's actually the same mechanism works on the cannabinoid receptor. So it's essentially very similar to CBD in that sense. We know that it is liver toxic, so in older patients that have liver dysfunction, I generally recommend not to. You can schedule it rather than PRN. You want to avoid the opioid non-opioid combo with acetaminophen, such as Norco and Percocet that include Tylenol. You don't want Tylenol toxicity. Doses above 2.6 grams are unlikely to provide further analgesia, and doses over 4 grams are likely to be toxic in the long run. If you have cancer pain, calcitonin is very effective in relieving the pain due to excessive bone reabsorption, specifically in metastatic cancer, compression fractures, Paget's disease, and osteoporosis. Basically, it's a nasal spray you basically in your nose daily. There are adjuvants, and you always consider this cancer pain. It's usually sodium voltage gated calcium channels. Calcium voltage gated calcium channel blockers, tricyclics. They're very effective in neuropathic pain, such as diabetic neuropathy, post-herpetic neuralgia, radiculopathy, spinal cord injury, or spinal stenosis. So this is a different classes of neuropathic adjuvants. You see methadone, ketamine. They're usually they're an NMDA antagonist. This prevents windup. It's usually in the spinal cord. It's Rex lamina 5, which is where this action takes place. There's a calcium channel blocker such as Neurontin and Lyrica, tricyclics, siRNAs such as Cymbalta or serotonin norepinephrine reuptake inhibitors. There is a sodium channel blocker such as Lidoderm, sodium calcium channel blockers such as Topamax and Tegradol. There are alpha-2 agonists such as clonidine and tizanidine, but you have to be careful because they also drop the blood pressure. Also substance P inhibitors such as capsaicin. There are other adjuvants such as antispasmodics, baclofen, scalaxin, neuroleptics, and compounding gels and creams. However, due to insurance reasons, they're not very common anymore. So when do you prescribe opiates for non-malignant pain? you want to start very slow, and actually, if you don't adequately treat them, they're more likely to have delirium from pain. So it's actually, there's a study done, and elderly patients may drive better when the pain is treated with opioid analgesics. So when you see people on medications, you want to be realistic expectations. You want to see that they're motivated, they're working or willing to adjust their work environment, they have a supportive home environment, and that is not enabling, and they're adequately treatment of psychosocial issues. You want to have well-defined goals. You want to define what makes their quality of life. You want to make sure they're compliant with physical therapy, occupational therapy, psych, or other medications. And you want to see lifestyle changes in weight loss, cessation of smoking. Some recommendations for opiate treatments: you have a pain contract. You should have a diagnosis, why you're prescribing it, whether they have recent or remote substance abuse. And as you may have heard, usually one physician prescribing and one pharmacy dispensing. And opioids are usually a trial, and it's not advisable to use other modes than orals, such as patches or suppositories or injectables for opioids. Opioid side effects, these are all present. The one that doesn't get better over time or develop tolerance is constipation. Opioid-related constipation should be treated prophylactically. It's actually intolerable for some patients. It's more painful than the pain itself. It's you don't develop a tolerance for it. You can use CNS, which is a stimulant. Adverse effects. You want to desensitize to, so basically everything goes down, has a tolerance except for constipation, and constipation usually occurs 7 to 10 days of the opioid use, and most of the time within the first 3 days. How to begin? Well, morphine is usually seen as the opioid choice. It's one of the medications that began the whole genre. You start low, go slow, use adjuvants also, such as Cymbalta, Effexor, gabapentin, Lyrica. That's a picture of the poppy seed. The goal is, if you require too much short acting, you want to switch it to a long acting. Therefore, you see long acting on the chart. Patients may require different opioid regimens for continuous baseline pain, and in between, you'll see breakthrough pain medications. Some long-acting opioid preparations, and these are long-acting, such as fentanyl patches, morphine, controlled release, Emiscontin, Avinza, Cadian, oxycodone, controlled release, such as OxyContin, or Xtampza, methadone. Oxymorphone has been taken off the market. So starting doses are usually every 4 hours as needed. If you require around the clock titration, then you take the total amount of opioids taken in a day, and you half it by 50%. That would be the long-acting dosage. When you do the math, you can convert everything to PO morphine equivalents. Some basic math is a Norco or hydrocodone is equal to morphine. So 1:1, oxycodone is 1.5 times stronger than morphine. Hydromorphone or dilaudid is 5 to 7 times stronger than morphine. So here's a sample opioid regimen. You start PO Percocet 10-325 milligrams Q4 hours. The patient takes 2 or 3 tablets a day, so you probably have 20 or 30 milligrams of Percocet. You probably don't need to convert to long-acting. But if you take 6 tablets a day and has continuous pain, you take 10 milligrams oxycodone, get 16 milligrams oxy, you take 50%, you can convert it to long acting. So 60 of oxy, convert it to 30, then you split that to twice a day, and that would be 15 Q12. And you cover that with breakthrough oxycodone. For methadone, great medication. It's an opioid with a NMDA antagonist. However, you have to really start low from the beginning. Opiate intolerance does not equal methadone tolerance. You start low, 2.5 or 5 milligrams Q12 hours around the clock for pain. You titrate up every 2 weeks, and you can reduce the previous opioids by 30% at a time. You want to do an EKG because it can prolong the QT, leading to arrhythmias if it's over a high dose, usually 150 milligrams. So the best options in kidney failure with no metabolite are fentanyl, which is long-acting, methadone, which is long-acting, hydromorphone, which is dilaudid, short-acting. Other interventional treatments that you see prior to surgery are intralaminar epidurals, transforaminal epidural injections, facet medial branch nerve injections, sacroiliac joint injections, shoulder, hip, knee injections, radiofrequency modulation, ablations, advanced interventional procedures. Interventional therapies are generally used in the very young and in the older patients to prevent long use of opioids, which has their own side effects, such as decreasing the immune system, causing abnormal hormone balance. Also minimize the needs for these narcotics and increase compliance with their exercise therapies. So for this multidisciplinary approach prior to surgery, the treatment of acute and chronic low back pain should include the multidisciplinary approach, such as education, active self-management, gradual resumption of normal light activities as tolerated, prevention, access and manage psychosocial factors, appropriate and individualized medication regimen, exercise program, imaging, procedure, surgery when appropriate. Again, here are some guidelines for low back pain. And that's it.
Well, that concludes today's program. Thank you so much to the presenters for all the time and effort that they put into putting together these presentations for us. Just a reminder, everyone will be receiving 5.5 CEU credits for today's program. Have a nice evening.